We are live.
Okay. Very good evening to one and all of you here. We have the cream of expert panel and a great set of speakers. And we are going to be now going into this update series of ARC in dwelling on DACRYOLOGY Decoded. And I truly believe this is not a topic just for the oculoplasty surgeons. And I'm sure any of us in the anterior segment are going to find great value attending it. And I do hope, dear attendees, all of you stay right till the end, because each of these speakers are going to really share pearls of wisdom. We are truly lucky to have with us Dr. Javed, who heads the Institute of Dacryology at LV Prasada Institute and a specialist in ophthalmic plastic surgery and facial aesthetics, an amazing surgeon. And I'm sure he's going to be the star performer in this webinar. We are very lucky to have with us Dr. Ravindra Mohan, who's a senior consultant and Gleneagles Global Health City. Again, a very prolific surgeon, known to not just in oculoplasty circles, but all over as a leading ophthalmologist of the country, and is also the Secretary of Oculoplasty Association of India. With us again is our dear Dr. Lakshmi Mahesh, who's again a very senior reputed ophthalmologist, oculoplasty surgeon, who's definitely going to add a lot of value in every single talk in this webinar. And we are truly, truly delighted to have her with us. And she's practicing oculoplasty at Chakra World Hospital, Bangalore. We have with us Dr. Vikas Menon, who's a senior consultant at Center for Sight Group of Hospitals based at Delhi, again with expertise in ocular oncology, oculoplasty, and facial aesthetics. And we are truly thankful to have this young, dynamic surgeon amidst us. We have with us Dr. Saptagirish Batla, who's again head of the Department of Orbit and Oculoplasty and also Dean at Shankara Eye Hospital, the Bangalore branch. And again, a very prominent figure. And thank you so much for being with us today. We have with us Dr. Raman Mittal, who's another very proficient oculoplastic surgeon and a medical director of Eye and Plastic Surgery Center from Amritsar. Thank you, Dr. Raman, for being with us. And finally, my very special thanks to Dr. Shreya Shah, a dear friend, and who also a very dynamic surgeon. I think it is not just oculoplasty. I can ask her to do any surgery and she would have it offered to her on a golden plate. And she again is one of the leaders of Drashti Netralaya Ophthalmic Mission Trust. And most importantly, moderating with me is Dr. Arvind, who has his own practice, Samara Vision Center at Chennai, and who has come through group of Arvind Eye Hospitals and Utah Lake City, an amazing, prolific, dynamic surgeon, and who is going to lead this moderation in the most beautiful manner. And I'm sure I'm looking forward to learning a lot from his moderation and all the wonderful speakers here. Without delay, we shall go on to Dr. Mohammed Javed, who is going to be talking to us on a very relevant issue, which is going to cover all of what we are going to be doing in the next 2.5 hours. He's going to talk on dacryology, past, present, and future. On to you, Dr. Javed.
Thank you, Dr. Chitra, for this opportunity. I thank AIS and Dr. Chitra again for giving me this opportunity to speak on this topic. And I'm realizing that as you keep becoming an expert, you start getting a little more philosophical topics rather than hardcore subjects. So when Dr. Chitra asked me for this particular topic, I really thought, what should I be presenting on that? I really had to do quite a bit in getting this presentation in a little shape. This is a tribute to all these gentlemen, so many of them who have worked. I think because of them, I am able to speak on this topic today. These are my financial disclosures. So I don't think this audience, the very august audience need any introduction to the lacrimal drainage system, but I would divide this talk as past. Why was it neglected? Why the science was neglected in the past? and the present, I thought I'll just speak about 9 years of my journey into lacrimal sciences and the road less traveled, and we'll probably just touch upon what the future might be holding for us. So as we know that lacrimal drainage system is an anatomical marvel. I'm yet to come across a drainage system, whether it is man-made or elsewhere in the human body or in animal system, which is as dramatic and as beautiful as this system, with phenomenal one-way channels to not only drain things out. I'm realizing as I start working how significant these systems are there and how they have evolved over a period of time. For example, if I remove the lacrimal drainage system from snakes, they will not be able to survive probably a day because they will not be able to identify between an enemy and a prey, and a lot of environmental sense that happens. Because all those tears from the snakes are then transferred to the vomeronasal organ, which is a sense organ, through the lacrimal drainage. So it has a lot of existential value, and I'm starting to realize its significance in even in humans. For example, it's very important in iodine recirculation in humans, for example. So there's a lot more to it than just draining the tears. And our recent work on the lacrimal pump mechanisms have shown some phenomenal insights as to how these systems work, just like a cardiovascular system pumping blood out and in just the same way that tears here. I won't go into any of these details. I just want to just give a touch of things. Dacryology, Dr. Ravindra Mohan might know, has fascinated me from long time. And this is one of my photographs from my residency, where this art had captured my imagination. So why was this science neglected? Well, I'm just contemplating. There could be many reasons for that, and I still do not know what was the reason. But I'm just contemplating. Was it unknown? No, it was not unknown. In fact, the first incision onto lacrimal sac was described in the Code of Hammurabi in 20 to 50 BC. So it's not unknown. And then Eber's papyrus had actually described treatment for lacrimal sac infection as a mixture of antimony and wood powder along with the dried honey. So these disorders and its managements were known from antiquity. So why was the science neglected? Was nobody interested? Again, that's not true. A lot of people were interested, but they were also interested in many other things. So why was there no focus? Were these very rare disorders? As we all know, lacrimal, for any ophthalmic plastics practice or even ophthalmologist, lacrimal disorders are not rare disorders. And this is just the outpatient of 5-year data that we had. We have close to seen 100,000 patients of lacrimal drainage disorders. So why were they neglected? Was the spectrum limited? Not really, because if you see, there's a lot of spectrum for the adults, for the pediatric patients, and it affects almost every aspect of quality of life, epiphora as such. So that can't be a reason. Was it because it was not a killer or not a blinding disorder? Well, that I'm just contemplating, though there are examples, lacrimal drainage disorders causing that. Lower socioeconomic affliction, or is there a gender bias? These are all contemplated things. I'm not sure why was it neglected. But what I'm gathering is that the territories were unknown. The ophthalmologist was not very happy because he couldn't assess the other half of the system in the way it's supposed to be. Similarly, the ENT guys were unhappy, bleeding in messy fields, probably poor monetary rewards. And then somewhere very early on in my career, this was a patient shock which made me realize certain things. This was a patient of punctal stenosis who had attempted a suicide because of epiphora. And till that time, I never expected somebody would ever think of doing that, or it was just, out of my purview at least. So my realization very early on became that these disorders were very common, yet not known the way we are supposed to know them. The disease has a very high nuisance value. There's wide spectrum of disorders, eye-threatening infections, but unfortunately there was no focus department. There was no focus individual who was working. And my question to myself at that time was, why no lifelong singular dedication? And that's where I remembered Mr. Einstein, who had once said, ask not why, ask why not. And that is where the journey began in 2013, when January, I would say, 2013, when LVP allowed me to focus on lacrimal drainage sciences. And then we started looking into the past, whatever was available, last 220 years of existence of LVP at that time. So we did a lot of things very early on, 2014, probably in a year's time. I realized that it's very critical for me to combine the rhinology skills with the ophthalmology skills, and that's where this gentleman that you see, Peter John Wormald, was gracious enough to take somebody who was not an ENT into a subspecialty of ENT and train him into rhinology, for which I am grateful to him for that. And then very early on, I also realized that if we really want to do something significant, then we need to have a combination for any science. One may be a very good surgeon, but is he a fantastic clinician? And a fantastic surgeon and a fantastic clinician, if they come at the same time, then that's a very lethal combination for progress of any kind of science. And that's where I started my PhD in biochemistry and glycobiology, to be more specific. And then from there started building up DACRYOLOGY services. And then the photograph on the right is the place where I'm sitting today, the same place, labs in Nuremberg, where I learned a lot of molecular biology. And this happened. I happened to meet the family of this gentleman, Mr. Govindaram Shiksaria, who was called as a cotton king of the world. And he was the first Indian to be listed on the New York Stock Exchange and a founder of Indian Stock Exchange. Somebody who has done a phenomenal work. And his family was gracious enough to part with 20 million for this institute. And that's where the foundation came about in 2016. And from there, the journey of present started. And this gentleman onto and the photograph that you see, Gulapalli Nageshwar Rao, told me something very early on, and I think I took it a little more seriously. He said that create new knowledge, disseminate new knowledge, and practice new knowledge. And I think that's precisely what the present for me was, where we described several new diseases, their descriptions and clinical pathological patterns and their managements. We discussed and described either new surgical techniques or modifications of the existing surgical techniques. We created new knowledge in a lot of basic sciences, especially with regards to Mitomycin C, which Vikas will talk about later on. And obviously started on other aspects of basic sciences away from the molecular biology into electron microscopy. And then electron microscopic work on punctal stenosis was recognized by ASOPRES as the most pathbreaking work of that year for etiopathogenesis of any disease. The other aspect was practicing new knowledge, and we had leadership roles in three-dimensional high-definition endoscopy and continuously variable endoscopies, and their utility in lacrimal drainage sciences, utility of ultrasonographic techniques and ultrasonographics guided surgeries, and disseminating new knowledge through obvious modes that every one of us do around. And I just highlight this as an example of one of my very early on fellows, Saurabh Kamal, who had put up his own experience of his fellowship in one of the surgeries, lacrimal surgeries. So today, it's lacrimal drainage system at this point is in a I feel in a right shape to go into the future. We have major treaties on this, and we'll also have further edition very soon of these things. Our group had 537 publications as of date in lacrimal sciences. And this gentleman that you see, Frederick Paulson, through my Humboldt research, helped me a lot in understanding the molecular biology. And very soon enough, the book that I grew up on during my fellowship in 2010, I was asked to write forward for that one. And obviously, the idea behind putting up this thing is that if you take road that is less traveled or not traveled, and if you have the courage to lose the sight of the shores, then things will happen and recognition will come in due time. The future, I think future is something that we create in the present. And if I go by what is possibly happening across the world now with the star speakers, when I was a fellow, I couldn't imagine having a dacryology webinar or such galaxy of stars around in this thing. So that's the very fact that if so many people are interested, and if I feel that the science is in very, very able hands of youngsters who will take it to the next level. Near future, I see that we will work a lot on focusing on understanding the things. The problem with lacrimal sciences has been that we don't understand the things, neither the anatomy, neither the physiology, at the fundamental level, what is happening. So I think the shift will focus from being plumbers and carpenters to a little understanding the disorders a little better. And in distant future, I foresee preventable methods to prevent pando, for example, or rescue strategies so that the patients don't have to go through the surgery. So while we all do this, there's so many youngsters. I would say that, do not forget to pursue your hobbies, whatever you want to do in life. It's something that's you should always pursue, because that keeps you happy. And if you are happy, then you will work very well in science. You should confront your fears. I like this example. I'm really scared of cobras, but now I'm starting to handle them. So you have to confront your fears, roam around the planet. Life is very short. So you should see this planet. I'm not sure whether I'm going to come back again or not. So see the planet and seek blessings from everywhere so that the science progress. Thank you very much.
Thank you very much, Dr. Javed. That was a very interesting talk. Like, I'm sure all of us heard every word of what you said, and it got us all thinking seriously. I'll take one very basic question with Dr. Ravindra Mohan on this in connection to the general trend of this session before Arvind takes on. Dr. Mohan, what I wanted to ask was, you have those had those guidelines post COVID for doing SAC surgery. Have you all given up all of it, or are you all still holding it, or to what extent you feel it's relevant? And one small question, is DCT obsolete now? It's never being done anymore? These are my two questions.
You want me to answer the question on COVID guidelines? Hello, am I audible, Chitra?
You're audible, sir.
Yes.
Yeah. So I think COVID guidelines, at the peak of COVID, many surgeries were not being done, particularly in this context. Lacrimal surgery was off for quite some time. And when we restarted, we had, depending on the protocol locally applicable, either one COVID test or two COVID tests consecutively to be negative within 72 hours, and HRCT in case the patient is going in for GA. I mean, the HRCT part was not always evidence-based, but for the safety of the anesthetist and the team in the OT, HRCT as a screening tool was also being used. But all that has been stopped long back. Now, I think after the end of the second lockdown, the COVID preoperative testing, the nasopharyngeal swab or oropharyngeal swab, that has been stopped. And now today, except if the patient is having fever or something, which is in general a contraindication for surgery, I don't think we are doing anything other than what we were doing in 2019. So I think we've come almost a full circle, at least practice in Chennai, and I'm sure in most parts of India. So if anybody has got a different take on it, that would be useful to discuss. But as of today, we're back to full-fledged surgery, no preoperative COVID screening, and just the usual preoperative assessment which you do when the patient comes in for admission or They're told to inform in case there is any fever. Other than that, nothing particular is being done.
And a very small second question which I asked.
Yeah, I think DCT is a surgery that has been given up for quite some time in most centers. For example, in the whole of my stay in Shankarnetralaya, for over a decade with doing fairly high volume lacrimal surgery, I did exactly 5 DCTs. Maybe 10 or 20 or more times, or 30 times that number of DCRs. And the DCTs are all for patients who had a preoperative possible diagnosis of a sac tumor or rhinosporiodosis or something else. So a routine DCT was not done for a nasolacrimal duct block in which a DCR could be done. So there is no age above which you shouldn't do, because today anesthesia has moved away where you can operate, in utero, and you can operate 95-year-olds for a fractured hip. So those are no longer reasons. But still, I feel now that I also work in some other institutions which have lesser resources, that if it is a bilateral total cataract, that means the patient has waited long enough for the cataract to blind him or her with no support system to bring them to a hospital. And by means of a screening camp or a charitable hospital, they land up at your center, and patient has bilateral NLD block, then what do? You do one DCR or both the DCR, send them back, bring them back again, in which case. So in that very limited context, actually, I have done more DCTs after leaving Shankarnetralaya than before. But at that time, I was a pure, institutional guy and practicing medicine the way I thought it should be practiced. But there are certain indications in our country still. Elderly lady, frail lady, bilateral NLD block and bilateral total cataract. What do you do? So I will leave it to Javed and all the others to also discuss about it. In such patients, a limited number of patients have done bilateral DCT. Wait for the shortest time possible where you think that the risk of infection is not there, and do the cataract surgery.
What is the shortest time?
Shortest time, I think I have waited is about a week. Because if the skin epithelializes and there is no nidus of infection, then I think you could.
Yes, Dr. Arvind.
Dr. Javed, thank you for that wonderful talk. I would always like to credit you with the kind of recognition you brought to dacryology and the kind of constant curiosity that you're capable of to try to find out new solutions to old problems. I'm just going to direct the discussion to one question. I know your work on punctal stenosis, and there are a lot of general ophthalmologists also in this webinar. What would you advise when we see a punctal stenosis? Should we go ahead, dilate, or I'll let you answer that. What should we do and what should we definitely not do?
Well, thank you, Arvind. As far as punctal stenosis is concerned, it's something which is very common, seen almost in 8% of any patients who's walking into an ophthalmic clinic. So the incidence is quite high. So those people who are symptomatic at present, we normally dilate them, simple dilatation, and place a Monoka at this point of time. I probably don't remember, maybe 4 years back, I might have done a punctoplasty, so I don't cut those tissues anymore. And if you look at the recent editorial I've written for Orbit, where over the last 8 years, the work that we build upon, we have now convincing evidence to say that punctoplasty is a surgery that should at least not be practiced routinely. So that is where we stand. Now, going ahead with punctum dilatation and Monoka, we are, there is also a lot of issues that can happen with stents. So at present, we are moving towards assessing coronary BDCP as one of the modalities where we may not have to place a stent post-operatively, because 71% of punctal stenosis have associated canalicular stenosis. So you would also like to dilate the canaliculus simultaneously. So at present, I'm exploring the possibilities of using coronary balloon dacryoplasties, because you get that at 0.7 and 1 millimeter diameters, which we don't get for lacrimal. So let us see what comes out of it. But as of now, a simple dilatation with stents usually suffices for most routine cases.
Do you recommend perforated punctal plugs? They're not.
Well,
Go ahead.
Well, I usually don't. I don't, because perforated punctal plugs, or for that matter, any punctal plug, is not designed anatomically for housing in the punctum or the proximal vertical canaliculus.
Shall we go on to the next
Go on to
speaker?
the-
One more question. We can, okay. So do stay with us, Dr. Javed. We need to learn a lot from you. We shall now go on to our next speaker, Dr. Akriti Desai, who's a consultant in ophthalmic plastic surgery practicing in Mumbai and a product of the very famous LV Prasad Institute. And she's going to tell us on anesthesia in DCR, a very important topic. On to you. Would you share your screen, Dr. Akriti? Is she with us?
She's not responding. She's there.
Where is she? Dr. Akriti? Yes, can you share your screen and start? You're having a problem at your end? Mr. Sunil?
Yeah,
Dr. Aditi, can you start your camera also? There is a network issue at Dr. Aditi.
Maybe we'll give her some time. I think there's a lot of rains in Mumbai, so she's having a problem there. Let's go on to the next. We'll go on to the next speaker, Akriti. Once you are fine, you indicate to us and we come back to you. I would now request Dr. Sonam again a consultant in Orbit Oculoplastic Aesthetics and Reconstructive Services from Shankar Netralaya, Chennai. Yes. From Chennai, and she is going to be telling us about ophthalmic evaluation in DCR. Let's hear this very energetic woman telling us some more. On to you.
Yes, thank you so much, ma'am, for that kind introduction. And at the outset, I'd really like to thank the entire organizing committee for giving me this opportunity. So I've been asked to talk about evaluation of epiphora, and I'll be obviously covering the ophthalmic investigations of DCR as well. So, well, I just like to put the title that there's nothing to cry about epiphora. We all know about the lacrimal drainage system and the lacrimal apparatus, which actually consists of the punctum, the canaliculus, the lacrimal sac, and the nasolacrimal duct. What is also important to understand that the ocular surface and the eyelids also play a very important role here. So when a patient comes to us with watering, we need to understand that there are two components in watering. One is lacrimation, that is hypersecretion, secondary to an underlying pathology like any underlying infection, a foreign body, and so on. And then there is epiphora. That is because of any altered or compromised lacrimal drainage system because of an NLD obstruction, canalicular stenosis, or punctal stenosis. So when we talk about evaluation, it goes back to our basics. That is any evaluation that we've learned way back in our MBBS. History taking is extremely, extremely important, followed by your inspectory findings, your palpatory findings, slit lamp evaluation, that's add-on findings that we can find, and imaging also. So history taking is very, very important. We start with obviously looking at the age of the patient. You have to ask for the duration, type of watering, onset, and the type of discharge that is associated itself will give you an idea whether there is mucopurulent discharge, there's mucoid discharge, or it's just plain watering. Also, you need to look for any associated complaints, whether there's any associated pain or any swelling around the medial canthal area. Any history of trauma also has to be ruled out. Any history of previous surgery or infection also must be asked for. We also must keep in mind systemic diseases, as we know that dry eye is associated with a lot of systemic conditions. Punctal stenosis can occur as a cause of many drugs that are being given. And we should not forget asking about any topical medications like AGMs, that is anti-glaucoma medications also, because we know that AGMs are associated with punctal stenosis and a lot of other ocular surface conditions as well. So when the patient comes to us, the first thing that is glaring is the tearfilm meniscus height. That is the first thing that will give us actually an idea about what's happening, whether actually the patient has any watering, is there any blockage, or what is the thing. So tearful meniscus height is one of the most important evaluations that you can do without even touching the patient. Next, you have to look at the periocular area as well. You have to look for the lashes, how the lashes are. Any chronic epiphora, watering, or an NLD obstruction might be associated with matting of lashes as well because of any mucoid or mucopurulent discharge, which is causing stickiness there. Next, we also need to look for the periocular skin because of constant rubbing of the tears. Many patients that you see might come to you with a little bit of periocular hyperpigmentation, periocular scaly skins, or any contact dermatitis because of epiphora as well. So these are the three things that we must also look into. Next, of course, we have to look at the lids. We have to rule out any lid malpositions such as ectropion, entropion. Also look for the blink rate and evaluate the entire face. Yes, nowadays we're seeing all patients with masks on, but it would be very nice if you could just remove the mask and also assess the facial asymmetry there. We have to assess the blink rate. We have to assess the orbicularis tone and look for any lag of thalamus as well. So when you talk about the lids, we have to look for any lid laxity, which includes doing all the standard tests that we do for lid laxity, such as your snapback test, your distraction test, as well as your you have to look for any floppy eyelids as well. So all these tests must be done as a patient department when we're actually looking at the patient as well. Medial canthal and lateral canthal laxity also must be assessed for. Next, when we are inspecting, we must look at the medial canthal area as well. Why? Because yes, that is where the sac is. It lies in the lacrimal sac fossa. Any inflammation, any acute or chronic dacryocystitis, any lacrimal sac fistulas can often be missed. So that is one area that we must assess properly. Now, one point to notice here is, why is this line here? We all know that the any lacrimal sac inflammation that is related to NLD obstruction generally does not cross about 2 millimeters above the medial canthal tendon. That line technically indicates your medial canthal tendon. In case you see a mass or a fullness in the medial canthal area, which is actually extending beyond 2 millimeters, then we must be a little worried and suspicious. Ask for imaging because it could be a lacrimal sac tumor as seen in this case as well. Coming on to the next thing, ocular surface. Yes, ocular surface is very important. We must not neglect that. Ocular surface, why? Because we have a lot of patients with chemical injuries or any cicatricial conditions like OCP who might come to us with epiphora and watering. It is very important to look at the phonicis, to look for any symblepharon scarring. Also, it would be wise to avert the lid and look for any scarring in that area. Look for any LMK, that is any keratinization also, because that itself can cause your hyperlacrimation. And we must identify we must identify the underlying pathology and rule it out. In slit lamp examination, it will be very important to assess the puncta size, shape, and position. And many a times it is very important to assess the puncta, especially in CNLD patients, because when you take up the patient and you see the patient actually had punctal agenesis, how are we going to explain to the parents that we cannot do a probing? So this is one thing that is very important that we must look for. Of course, Centurion syndrome, that is anterior insertion of the medial canthal tendon, also is one of the causes of epiphora. Canaliculitis is a masquerade of nasolacrimal duct obstruction, and that is something that must be looked for. The most important test is Roplers, that is regurgitation on pressure over the lacrimal sac area. And it has been proven that self-Roplers can be used as a screening tool for the patients. When we're doing syringing, these are the tools that we must keep ready in our OPD. And syringing, probing is very, very important. In children where we cannot do syringing, we can do a fluorescent dye disappearance test. As you can see in this trial, you can see FTP at 3 minutes and 5 minutes is much higher as compared to the other eye, suggestive of an obstructive etiology. We generally tend to use a 26 gauge needle for syringing, and you can start probing with 00 probe. If you get a hard stop, that is suggestive of a nasolacrimal duct obstruction. But if you get a soft stop at less than 6 millimeters, proximal canalicular block, more than 6 millimeters, suggestive of a distal canalicular block. So these factors are important in also planning your surgery. This is just a simple 3-probe test that I'd like to highlight to also talk about lacrimal fistulas, congenital fistulas, because that will actually tell you where exactly the fistula is originating from. You can trace the tract and then excise it or plan the management accordingly. To conclude, imaging plays a very, very important role in assessing nasolacrimal duct obstructions also. This is a case where you can see it's actually a dacryocyster seal or a dacryocyster seal. We just had to go ahead and do an ultrasound and we figured out what the fluid was. a child underwent probing syringing. Of course, he had a large intranasal cyst, which was seen in nasal endoscopic evaluation, which my colleague Dr. Pratibha will be covering. DACRA cystogram, CT DCG, and MR DCG is also a very important investigations of choice, especially in cases of traumatic NLDOs or INDOs, that is iatrogenic nasolacrimal duct obstructions. It actually can tell you where the sac is avulsed or what exactly is causing trauma at the level of the sac and NLD, and can help you plan your surgery much better. It's a very simple procedure. You just put a dye. Either you can put as a drop or you can inject the dye, and then you take serial sections, and you can see here in the image how beautifully you can see that here there is a 2-point plate which is actually dissecting and causing avulsion of the sac and the NLDO. And you must do imaging in special concentration, like this patient who actually has a arynia, and you can see that she has only one nose, but right side she has a sac and she had Rockla's positive. She had a nasolacrimal duct obstruction. Technically there was no nasolacrimal duct here. So in order to plan your further surgical management, this imaging will help you plan better. And to conclude, yes, hemolacria is another condition where you might have NLD associated with hemolacria, like in case of rhinosporidiosis, and you must do a thorough evaluation for the same. And also be aware of malingers like this, who actually came to our OPD saying that she had bloody tears, but you can see what she's actually done. She just painted around herself. To conclude, we must identify the cause. It is very important to assess the level of the block, identify the cause, do a detailed evaluation, and when in doubt, always image. Thank you so much.
Wonderful talk. Wonderful, crisp talk, and covered it all beautifully. And one basic question, Dr. Lakshmi Mahesh, if a patient has a sac pathology and also a lid abnormality, would you do them as a staged procedure, or would you do them both together?
Yeah. You mean to say a lid abnormality and a sac procedure?
Yeah.
Definitely the sac first.
Okay.
Always the sac first. But if the lid is a minor problem and the sac infection is well controlled, sometimes you can think of repairing it in the same sitting. But if it is a deep wound or a deep defect or something like that, first it's better to repair the sac. But there are a lot of injury cases when there is a lacerating wound of the eyelid that has to have a repair. And in that, if the NLD is exposed, if the sac area is exposed, then we could do a DCR or finish the repair of the lid first and subsequently do the DCR. We can't leave an open wound of the lid though. This is in acute injuries. But when you get a chronic condition and you have to work on the lid for further reconstruction, it's better to fix the sac first.
Dr. Arvind?
Thank you, Dr. Sonam, for bringing all your energy into the talk. My question is to Dr. Shreya Shah. Even today, we get referrals of patients who sometimes have canaliculitis, but who present just like a chronic dacrocystitis. What are your tips for differentiating both these conditions, madam? Dr. Shreya, you are muted. Can you please unmute yourself?
Sorry. So when you see the patient, when you suspect the patient for canaliculitis, usually they come with pain, first thing. Usually when there is acute and chronic dacryocystitis, the history will tell you that it was repeatedly NLD block and now they have come for acute and chronic. But when there is a canaliculitis, the first thing, the moment you dilate and you try to put the probe, the whole things come out immediately. It's like popping up the pus from the abscess. So that one thing will definitely say. Second is you will be able to do syringing, and there may not be, they may be patent. So that is the sign that that is simply a canaliculitis. And when you see canaliculitis, you have to look for all other causes which are responsible for canaliculitis. The most important thing what nowadays is, even sometime it happens that simple acute conjunctivitis, it's not treated and it has created. Second is dacryolyth. So sometimes just small stone-like structure which stucks into the canaliculus, and it repeatedly causes abscess-like structure in the canaliculus, and then it becomes acute and chronic canaliculitis.
Thank you, madam. I think that is a very relevant topic, especially for people who are evaluating them. And unless we differentiate, even a great and well done surgery for the wrong indication will not actually benefit the patient. Is Dr. Vikas Menon here? I don't see your, I just want to ask you. Or Dr. Saptagirish, can I pass on the question to you? Can you please turn on your camera?
Sure. I'm audible, right? You can show.
Yeah, you're audible. My question is, how many CT DCGs do you advise? Do you have a thumb rule to decide who to image and who to go ahead with surgery without a DCG?
Actually, I don't do much of CT DCGs unless it's very much indicated. Like when I'm thinking very much of a tumor, actually, which is pressing on the lacrimal system, whether it's involving or not, I would not do a DCG. So, yeah, looking back for the past 10 years, I've just maybe I've ordered only about 2. Maybe that's what I got over here. And those 2 also were just actually passive compression, and we just got away with the removal of the lesion. So I don't routinely do a lot of CT DCGs. Maybe it depends on the practice, I guess. But you have to have the indication for doing it. You have to have a lesion, and you have to go by your clinical findings, and then you decide whether you actually need to do it or not. And in spite of, sometimes you may find a lax sac and you may think you'll do a DCG, but that's not going to change your management plan. So there's no point doing it. Well, that's my practice. That's the way it is.
So the speaker would like to add some points, so I'll give her an opportunity. Dr. Sonam?
Yeah, thank you so much. So we do CT DCGs, especially in cases of traumatic nasolacrimal duct obstruction. So where we know that there has been some intervention that has been done before, like in case of endo, because that actually helps us plan our management better. Whether we need to remove the screws and the plates, whether we need to trim the titanium implant medial flange, which is actually bifurcating the sac or not. So those cases, it actually helps us plan better. Also, like I showed the last case of arynia, when we do a CT DCG and we do an imaging in that case, it will actually help us plan where exactly you want to do the DCR, because generally in case of arynia, they say you can actually do it through the septum, like you can do it like a transseptal DCR, or you can also do a DCT depending upon the eye condition. So it would help us in planning better is what I would just add on to that. Thank you.
Arvind, a couple of points, I think.
Yes, Dr. Please.
Right. Now, I think right from the time when we initially started CT DCG, maybe about 15 years or 20 years back, the indications for CT DCG have actually widened in my practice. My threshold for doing a CT DCG is fairly low. I mean, I don't do it for all cases, of course, exposing a patient to radiation and things. But all cases of trauma, like Sonam mentioned, all cases of trauma, because it will help you to see the extent of scarring, callus formation, and any other distortion which you should be prepared for, because the surgery is likely to be more challenging than a routine pando case. The second is we have all the patients with failed surgery that are not clearly able to identify a cause in terms of whether the canalicular system, because the canalicular system is the bugbear. If you have an osteal closure, you can very easily open up the ostium from the lower end, like endoscopic, or from an open approach. But if there's a combined canalicular block as well, so this also helps us to delineate. I mean, a well-done CT DCG is a beautiful test which will help you to see the canalicular integrity, the relationships, the scars and things like that. Also, one unusual kind of a situation which we don't see that uncommonly is a failed DCT. Now, what is a failed DCT? A well-done DCT should be the end of the patient's misery, with the sac completely taken off and the canalicle is, ligated, scarred, cauterized, and the patient should live happily ever after. But there's a large number of patients who are operated at smaller centers by budding surgeons. It's pushed to the end of the list in many government and other hospitals, where the youngest postgraduates gets a hand at doing surgery. And these are not actual DCTs performed. Either a part of the sac has come off, or a part of the lacrimal sac fascia has come off, or everything has been abandoned because of bleeding. So there are many of these failed DCTs where they still continue to suffer with regurgitation and discharge and all that. And when you syringe, obviously it's blocked and some discharge comes out. So these to delineate, because if there is significant amount of sac tissue left, then I would like to go ahead and do a DCR after a DCT. I mean, it sounds a little funny that you're doing a DCR after DCT, but there are many, many cases where I have done that. And it's obviously for the patients better, rather than so-called going and completing a DCT. If only a very small portion of the sac has been removed or not even removed at all, then you would like to do a DCR for the patient and, you know, give him or her a better quality of life. So that is another indication where I found it very useful. Your radiologist can very clearly delineate and say that there's significant amount of sac tissue left for you to possibly go ahead and do a DCR. Or no, it seems to have been a well-done DCT. There's no sac at all. So in those cases, I would go ahead and remove whatever remnants are left and make the patient free of symptoms. I think these are the common indications. And anything extramural, anything which looks atypical. I mean, we see NLD blocks day in and day out. So anything which doesn't fit in, for example, the mass seems to be extending above the MPL or anything else which is atypical, you will go ahead and do a CT DCG, which will beautifully delineate your entire passages for you.
Thank you, Dr. Mohan. I think that kind of encompasses all the indications for a CT DCG. I think the message is there is an option for imaging, not for all patients, but for indicated ones, definitely it's something we can consider before planning the surgery. Now we'll move on to the next speaker. Dr. Akriti is ready with her talk, and I think her network issue is resolved. Dr. Akriti, can we have you online? Dr. Akriti is speaking on anesthesia and DCR. And
yes, good evening, everybody. Apologies about the connection issue that time. My topic for today is anesthesia in DCR. Yeah. So we all know as ophthalmology residents, we see a lot of students who are scared of DCR. They cringe at the thought of DCR. And so it's painful not just for patients, but it's considered painful for the residents themselves or as ophthalmologists. So a quick overview of the nerve supply of the lacrimal region. We have the infratrochlear nerve, which is the branch of nasociliary. We have the infraorbital nerve, which is the branch of the second division of the fifth nerve, that is the maxillary nerve. So these are the areas, nerves that primarily supply along with the anterior ethmoidal nerve, which is again a branch of the infratrochlear, which supply the lacrimal sac area. So these nerves need to be blocked while you proceed for the DCR in local anesthesia. But the eternal question always remains whether GA or LA. Historically, local anesthesia has been practiced long back in the 19th century, but current gold standard is general anesthesia, since it eliminates pain as well as elevates the anxiety associated with passage through the bone, especially while making the ostium. Although in elderly patients or patients with comorbidities, GA can be avoided. Also, personally, in revision DCR cases, I prefer general anesthesia because of the scar tissue. The spread of local anesthetic is not very smooth. There are various pain scales, at least 10 to 11, but commonly they involve either the numerical rating or visual analog scales, wherein you can select a picture which matches your pain level and tells how severe your pain is, or categorical scales which use words along with numbers, colors, or in general location on your body. So this is a diagrammatic picture of how you can ask the patient how severe was their pain during surgery, and then moderate your technique accordingly. So preoperative nasal endoscopic evaluation is done in all patients, and a topical anesthetic spray of 10% xylocaine or lignocaine is used, just 1 to 2 puffs before performing evaluation prior to planning DCR surgery. If we are going ahead with local anesthesia, then first we start with topical anesthesia, drop of tropical proparacaine in the conjunctival cul-de-sac. The nasal mucosa can be sprayed with 10% xylocaine And packing is done with 4% lignocaine and 0.5% or 0.04% xylometazoline. Infiltration anesthesia includes 2% lignocaine with 0.5% bupivacaine or with or without adrenaline. And in external DCR, we can infiltrate it after making the ostium, in addition, so that we have better hemostasis while going, making the nasal flap. Coming to the role of adrenaline, let me go here, is there are various formulations available. There is xylocaine without adrenaline. There is lidocaine with adrenaline, which is 1 in 80,000 or 1 in 1 lakh or 1 in 2 lakhs. So it's important for any one of us to deduce how much of adrenaline is there in each quantity, in each of the solutions that we prepare. So in the 1 in 80,000 in 1 ml has 0.125 milligram of adrenaline, while in 1 in 2 lakh, which is this vial, has just 0.05 milligram in 1 ml. So it may not be as effective if we are using this solution for DCRs. I personally use 1 in 1,000 adrenaline 1 ml, 2 vials in 30 ml plain lidocaine for my anesthesia in DCR. So 1 in 1,000 comes to 1 milligram per ml. The technique of nasal packing is very vital. We direct superiorly and backwards. If we go along the floor, then we might end up in the inferior meatus. So our end goal is to locate our nasal pack in the middle meatus, which is going to be the site of future ostium. I'll just play a short video. I'm sorry, it's not playing.
You can just minimize your presentation and play separately, Akriti.
Maybe you should move on to the next slide.
Okay, fine. Yeah, 1 second.
Ma'am, you can stop and reshare.
Okay, in the interest of time, I'll move on to the next slide. Yeah, it's begun. So I first mark the incision which I'm planning.
You need to stop and reshare. The slide is stuck. Just stop the share and then reshare.
Is it okay now?
Yeah.
Perfect. We can see the video now.
Okay.
It's again stuck.
Okay, so I'll just explain. I mark a subciliary incision with a skin marker and then mark out the infra-orbital nerve at this location where it exists from the orbit, and also palpate with the non-dominant hand this supraorbital notch. And 26 gauge needle with a 2 cc syringe or syringe even to inject in the medial to the supraorbital notch, so that there is anesthesia of the infratrochlear nerve. Apart from that, the third injection is given locally over the anterior lacrimal crest and infiltrated subcutaneously, inferiorly as well as superiorly, to anesthetize the lacrimal sac region.
Some problem there. Poor network, Mr. Sunil.
Yeah, I think she's resharing it.
Yeah.
You can move to the next slide
Move
immediately.
to the next
fine.
slide. Yeah.
Also to remember for pediatric DCRs is obviously we would go ahead with general anesthesia. Adequate decongestion is needed. And we have to consult with anesthetists like in all GA, but more so for pediatric cases because they are more sensitive. We have to note that while nasal packing, the nasal cavities are narrower, and also there is a lower skull base in pediatric patients. So these are the factors. If you do it too forcefully, you might perforate the cribriform while inserting your nasal pack. In endoscopic DCRs, definitely general anesthesia is what I have done. I prefer to use.
1 minute left.
Okay, neuropathy is about 2 ml of normal saline with 1 and 1 at 1000 adrenaline or Vexel sponges. Infiltration of lateral wall and medial turbinate with 2% xylocaine with 1 in 80,000 adrenaline. The area to infiltrate is the maxillary line as seen endoscopically, what you can see here where the needle is being inserted, and the middle turbinate, so that the mucosa shrinks and it gives you more space to start your endoscopic DCR. Total intravenous anesthesia is with propofol and remifentanil. It helps reduce the blood pressure to about 60 to 75 millimeters of mercury, and thereby helps reduce intraoperative bleeding, which eventually tells how the outcome would be. This is an interesting article which I would recommend. Role of anesthesia in endoscopic and external DCR. They have studied multiple cases. Dr. Javed Ali has been an author on this, and they've concluded that endoscopic DCR with general anesthesia is definitely should be the solution of choice. However, local anesthesia associated with sedation can be used as an alternative in selected cases. But for external DCR, there's lack of data, so there were no meaningful conclusions regarding choice. Thank you very much. And I'm sorry about the connectivity issue.
No, thank you very much, Dr. Akriti. You did try to convey, and we lost out on that wonderful video teaching you would have done. On to you, Dr. Arvind.
Thank you, Dr. Akriti, for bringing out all these aspects. My question is to Dr. Lakshmi Mahesh. Despite so many DCRs, madam, I'm sure you would have seen that some people have excellent pain threshold and some people seem to be very afraid of undergoing a DCR under local anesthesia. Do you have a way of judging who should be given a little more attention? Would you prefer general anesthesia for your majority of your cases? What would you?
General anesthesia, thanks, Arvind. General anesthesia definitely for endoscopic DCR, but once you start getting a lot of experience in endoscopic DCR, you could get away with local, because the main problem in endoscopic DCR is the menace reflex. Every time the scope is coming right in front of your eye. Now for external DCR, my preferred choice, if the patient is not a pediatric patient, it's only local anesthesia with very good sedation. I give 6 hours of fasting for sedation, and I also get an anesthetic assessment done. So we really knock them off, and I would like to have BP on the lower side. I don't even inject anesthesia unless the BP is below 120. 130 is like the maximum cutoff. Above 130, I don't even go and put in. Now, she was talking about anesthesia. Sometime in 1995-96, Jeffrey J. Hurwitz, who was recently passed away, I think a few years back, he lacrimal surgeon in Toronto, brought about a beautiful textbook of lacrimal surgery, where he described about the 3-point anesthesia. I think all the youngsters should read. And it was written by none other than a Tamil anesthetist, Dr. Chidambaram. I think he has contributed to that chapter, a 3-point anesthesia. Now, I follow that technique religiously ever since I read that. In addition, I give a little more because the ethmoid bone needs very good, because every time the sac is well taken care of, when you start punching the bone, the patient starts wincing. So between the sac and the medial wall, you should give a good infiltration. You can use your 23 gauge 1.5 inch needle, but you have to be worried about the anterior ethmoidal artery, which is exactly around 24 millimeters from the surface. So I just use a 26 gauge needle, and you won't believe me, I give a 50% dilution. 1 in 200,000 adrenaline. Xylocaine, 2% xylocaine with adrenaline, 1 in 200,000 with Hylase, with 50% dilution, almost 12 ml of anesthesia gives a 3-point anesthesia. One is along the nasociliary, that is the curvilineal line. I don't believe in that subciliary incision. Then the second is a little bit you can give into the trochlea for some amount of anesthesia, again along the line of incision. Then the para-infraorbital block. Not exactly infraorbital, you keep it in that direction, but aim it towards the sac. It's or para or peri-infraorbital. And then the last one is, I have modified that over the last 20-30 years, between the sac and the medial wall. Give good infiltration. Small needle is enough. 2 cc syringe. With 5 cc syringe, you'll have a lot of resistance. These are all the tiny tips, and good sedation. And of course, after giving the anesthesia, give your nasal pack. Make sure you have Otrivin nasal pack. If you want, you can dip it in few drops of adrenaline. ENT surgeons are very bold. They just empty the adrenaline and pour into the cup. We are not like that because we are worried about all the tachycardias. Just put 1 drop in 10 ml of saline. It works wonders.
Wonderful.
Thank you, madam.
Yeah, can I add something?
Yes, Dr. Shreya, please.
Yeah, I totally agree with ma'am, because I'm also following the same thing. You little bit inject in the periosteum and then you don't have to inject much. You can do very well surgeries with small anesthesia. And what she talked about the pediatric anesthesia nowadays, if you use sevoflurane, it is a wonderful anesthesia. Anesthetists are using that within 5 minutes you can even suction and everything is very easy with that anesthesia, or laryngeal airway mask. These two are the safest anesthesia techniques for, especially for pediatric
pediatric cases. Don't go without intubation. You need to have intubation, because if you're giving syringing or other, even laryngeal mask is not so safe. So
but if you do with sevoflurane, it's okay. Because they are putting additional airway in the intubation.
Still, I would say that intubation is better. Yes. And Dr. Ayan Sundarraj, the grand old anesthetist in Shankar Netralaya, he had told me for all oculoplastic surgeries, we used to have a 15-degree elevation of the table for that is for minimizing bleeding. But for DCR, the endoscope, that is for probing and syringing alone, he used to give 15-degree depression, so that whatever collects for the pediatric case, it collects down and you can just suck it out,
Oh, good. Nice. Any other opinion before we go on to our next speaker?
I would just like to mention that right now, with the recent court verdict, anesthesia and especially for pediatric age group, is a very burning topic. And I think all of them should be evaluated properly. And even though the anesthetist is involved, it's a huge responsibility on us for the child or the patient to have a good outcome. Dr. Javed, I'll just quickly drop a question, because I know you are very liberal with using adrenaline in your nasal packs. Can you just give us a guideline?
Probably because I have a rhinology background.
Yes.
Maybe that might be the reason. We're not scared. I usually use 1 in 10,000 for endoscopic DCRs, and 1 in 10,000 has usually helped me out. So I think it's more about comfort, what Shreya was talking about or what Dr. Lakshmi was talking about. I think it's about your comfort, and as long as you can deliver it, and the settings matter. Like we have 15 anesthetists walking around us in ITLV Prasad. We don't really have to worry about anything, in terms of general anesthesia. For the smallest things, we can take them under general anesthesia and do that right away. But that may not be the case with the people working in different setups. So I think based on that and how comfortable your anesthetists are, and how well you also train your anesthetists to be comfortable with higher concentration of adrenaline, I think all those things are very individualistic.
Thank you, Dr. Javed. I think
on to our next speaker, Dr. Pratibha Devi, who's again practicing good oculoplastic surgery in MNI Hospital, Chennai, and very popular figure in the field of oculoplasty. And she's going to tell us something what we're already discussing. How do you do a systemic evaluation for our DCR patients? On to you, Dr. Pratibha. Pratibha, you are muted or what?
Yeah, sorry.
Good evening, everyone. Thank you, Madam, for the introduction and giving me the opportunity today to speak in this webinar. So my topic is on systemic evaluation. Dr. Sonam has beautifully covered the ophthalmic evaluation of epiphora. So my topic is more simple, and it is going to be the preoperative systemic evaluation. So systemic evaluation, when we talk about it, is mainly the systemic parameters and then the nasal endoscopy. So when it comes to systemic evaluation, the detailed history is very, very important. And then doing a proper blood evaluation is mandatory. So when it comes to history, a detailed medical history should be prompt and asked to the patient, because patient may not come out with those histories. They should be asked about history of supplements. They should be asked about history of scarring tendency. They should be asked about history of cold urticaria. So when you talk about medical history, we should ask the common question. We should ask about the intake of non-steroidal anti-inflammatory medicines, the oral anticoagulants, history of liver pathologies, history of prolonged bleeding episodes. So why is NSAID important in this aspect? So traditional NSAIDs, they block both cyclooxygenase 1 and 2 pathway. Cyclooxygenase 1 is responsible for the platelet function. So when that is blocked, the platelets function is affected, and there is a prolonged bleeding in such patients. So ideally, NSAID should be stopped 5 to 7 days prior to the surgical procedure. And when we talk about anticoagulants like warfarin, heparin, and vitamin K antagonists, people are given these medicines to prevent thromboembolic episodes. These medicines are given to prevent a thrombus, and so they cause increased bleeding tendency on table if they are not stopped. But several studies have shown that if these medicines are stopped abruptly, then they can cause a rebound hypercoagulability. So these in high-risk patients, proper clearance should be obtained from their treating physician. And even some physicians have reported that they give a bridging therapy with either a low molecular weight heparin or an unfractionated heparin during the surgery to prevent such thromboembolic events. So there should be a right balance between the risk of increased bleeding and such post-perioperative thrombotic complications, which are dreadful. So what we should do, ideally, we should get a proper clearance, stop all anticoagulants 5 to 7 days before surgery. And it is reasonable and wise to check the INR and consider postponement of surgery if the INRs are above 3. And this is another important aspect. We see a lot of patients taking herbal supplements which contains bilberry, chamomile in green tea, vitamin E in creams, fish oil, flaxseed oil, garlic, ginger paste. So these things are said to cause increase in bleeding. Leave about DCR, we deal with many cosmetic procedures. These herbal supplements are prone to cause more edema and bruise post-operatively. So our patients should be warned about the risk so that they are not very unhappy post-operatively because of the bleeding and because of the bruise and hematoma. So what can happen if these anticoagulants are not stopped? It can cause a simple lid hemorrhage or a prolonged bleeding to a dreadful orbital hemorrhage. So a dreadful orbital hemorrhage can lead to vision-threatening complications. Though rare, it should be kept in mind. So these things should be inquired and stopped and get a clearance accordingly. And in such patients who are on chronic therapy, the patients have to be taught about the risk of these complications and the symptoms which they develop. And these patients should be given advice to report to the emergency once they see symptoms of orbital hemorrhage like increase in proptosis, prominent edema, or in case if there is a poor desaturation test which is suspicious of optic neuropathy, they should report to the emergency immediately. So our patients should be taught about these in high-risk patients. And history of cold urticaria, though not very common in our country, history of cold urticaria should be asked. And if there is a history, immediate cold compress to reduce the edema should not be advised, because that could be potentially fatal in these patients. And coming on to the blood investigations, I routinely do the common basic blood tests like hemoglobin, TCDC, ESR, blood urea, creatinine, and bleeding time, clotting time with INR, and random blood sugars, the hepatitis and HIV profile. And I do a COVID testing these days. So this was also discussed. So I do it as an elective procedure if they are COVID positive. I, based on Dr. Javed's practice guidelines, we can triage the patient, and if it is an urgent surgery requiring an emergency treatment, then we can take up a COVID positive patient. Otherwise, we can wait for the patient to become COVID negative and take up the patient. And if they are COVID positive, sir has given beautiful guidelines. We can follow those guidelines if we are operating on a COVID positive patient. And many of our DCR patients, as already discussed, most can be done in local anesthesia. But if they require general anesthesia, particularly if it's a pediatric patient or if it's a highly anxious patient, then we have to do all these detailed evaluation which our anesthetist ask, and get proper fitness, including cardiac fitness if needed.
1 minute left.
And this is very important, nasal endoscopy. Nasal endoscopy involves evaluation of nasal and sinus passages. So it's an OPD procedure. So technique of endoscopy, the nasal packing, as Dr. Kruti has already pointed upon, I inject the nasal spray and then I pack the nasal passage with gauze soaked in Otrivin drops and lignocaine with adrenaline for at least 10 minutes before the procedure. And this is the endoscopic unit which I have, and then I do the endoscope. So what do I see? I see for the DCR site. So this is the middle turbinate. This is the root of the middle turbinate. I see for the space here, which is available. I see for any mass or any polyp. I see for the septum. I see for any septal hump or spur. And I see for the nasal mucosal abnormality. So what to do to prevent intraoperative surprises and to avoid postoperative disappointments, and missing a tumor can be a medical legal issue as well. So this is a small video of nasal endoscope. So here, so we start from the anterior aspect. This is the inferior turbinate which we see here. And then we go back. And now what we see here is the middle turbinate. And this is the root of the middle turbinate. This is the site of our endoscopic DCR incision. And then we go through the inferior meatus. This is the first pass. We go through the inferior meatus. And this is the nasopharynx. And then we come up and the middle turbinate, the middle meatus, the openings in the middle meatus, and the bulla ethmoidoides. So this is a normal nasal endoscope with a healthy mucosa and with no abnormality. So this is a grossly deviated septum, and when we deal with grossly deviated septum, we will have to do the repair and then take up of surgery. Otherwise, we will end up in failures. And there's a polyp here, and there is a tumor, cauliflower-shaped lesion here. So a nasal endoscope helps us to plan preoperatively and to avoid disappointments postoperatively. So when there is any other abnormality, an ENT specialist should be, a consultation should be done and treated appropriately. And according to literature, the common causes for failure of DCR are anatomical, pathological, and surgical, among which anatomical and pathological causes are the major chunk, which could be definitely avoided if we do a proper nasal endoscope. So the take-home message is we have to do a proper systemic preoperative assessment, do a detailed blood evaluation, and also do a good nasal endoscopic evaluation before a DCR to have a successful DCR. Thank you. Thank you for the opportunity.
Thank you, Dr. Pratibha. Such a thorough talk. You answered all the questions which I had for you. That tells that how deeply you went into it and gave us all that we needed to know. Dr. Arvind, would you take some questions with that?
Dr. Pratibha, thank you for a very wonderful endoscopic video.
Thank you, sir. I should acknowledge Dr. Sumati, our ENT consultant, for the video. Thank you.
Not the last slide acknowledgement, but really that kind of put things in place.
Yeah.
My question is to Dr. Saptagirish. Do you recommend pre-medication for any of your DCR patients? Is it a part of your routine?
Hi, Arvind. You know, I usually do not give any pre-medication as a routine. But I know my colleague in my colleague here does give little Restil, and he gives a preoperative painkiller also and all that. But I, as a routine, do not give. I perform most of my surgeries under local anesthesia, as Dr. Lakshmi Mahesh mentioned, and most of the patients are comfortable. Most of my practice is only external DCRs. I don't do much any endoscopic DCRs. It's just the opposite of what Dr. Javed does. And yeah, I mean, that's a patient profile that I have. It depends on that. And I don't do any pre-medication per se. But yes, if As Dr. mentioned, Pratibha mentioned that if the patients have little bleeding disorders or in a preoperative evaluation shows up that the patient is prone for bleeding, our anesthetist is consulted. We'll have a consultation with the hematologist, and we either keep a fresh frozen plasma or blood or what platelet extracts ready. And we do, if it's required, we do need to give it, we give it. But it is less. Most patients are quite stable. We do a good preoperative evaluation. So preoperatively itself, we've had patients where we've given them preoperative plasma and stabilized their INR and then taken up for surgeries. Patients who were already on anticoagulants, we ensure that the hematologist and the cardiologist give clearance before we even take it up. And of course, the INR is the thing that we look at, and that gives us a value, but nevertheless, bleeding can still take place. You do have small vessels which can bleed. It's mostly the capillaries which can cause a lot of bleeds rather than the major vessels, because you can always coagulate the major vessels or cauterize them. But the small capillaries are the ones that keep on bothering you. And so preoperatively, apart from the pre-op evaluation, pre-op preparation as such, no, I don't give anything much. I don't trouble my patients much. But yes, my colleague believes in giving Restil, and I'm sure many of them do it. I used to do it much earlier, but I don't do it now.
Thanks for emphasizing on the preoperative evaluation. I think we all agree that DCR is not a minor procedure. It does involve a lot of systemic features, and a good preoperative evaluation will ensure a smooth surgery and a good post-op outcome. I'll just pass this question around to the other panelists, Dr. Ravindra Mohan and Dr. Lakshmi Mahesh. Any choice of pre-medication as a routine for DCR patients?
Yes, I give Otrivin nasal drops 3 times a day, both nostrils, 3 days before the procedure for all DCR patients, endoscopic and external, all the more for endoscopic. And I also give Otrivin pediatric or Nazivion pediatric nasal drops 3 times a day before probing and syringing. It makes a difference, because I learned the endoscopic DCR the very hard way. Started sometime in 1996, and I realized that this works. And pre-operatively, I make sure the aspirin also is stopped at least 3 to 4 days prior. And if the patients are on clopidogrels or warfarin or Coumadin at least a week prior, get a cardiology, because patients are psyched about stopping it. I ask them to get an evaluation done and stop it 1 week prior. Because most of the times it's the bleeding which is so annoying. And I think for all said and done, it's a keyhole surgery, whether you're doing it externally or endoscopically. And hemostasis is definitely the key.
Yes. Thank you very much, Dr. Lakshmi. So we shall now go on to our next speaker, Dr. Shruti Tara, who's a Chief Medical Officer from Shankara Group of Hospitals based at Coimbatore, a very charming person. And let's hear her telling us how she would take care of hemostasis in DCR. On to you, Dr. Shruti.
Is my screen visible?
Yes.
Right. I thank Dr. Chitra for having me here. Thank you, ma'am. Actually, my previous speakers have made my life a little easier by covering a lot of aspects of what I'm going to touch upon now. Now, to prevent, tips to prevent. This is a very Manipal term, preventing DC war. So this would be probably in our early days when DCR was a very scary surgery, but it's actually not so bad. So what do we do for that? Now the systemic evaluation, my previous speakers have already told, Pratibha has explained in detail. I would still touch upon the hypertension, the bleeding tendencies, and the relevant investigations that we need to do. And I generally stop blood thinners a week before surgery. And if they're on warfarin, the INR to drop below 2. And as Pratibha said, the herbal concoction, yes, I ask them if they're on any herbal concoction, and it's a good idea to stop it preoperatively. Now, pre-medications, yes, I do give pre-medication. I start them on oxymetazoline hydrochloride or the Nacebian drops, 2 drops 3 times a day, at least a day before surgery. And I also give Angsit 0.25 milligrams in the night before surgery. It simply makes them to rest well and they're less anxiety the day of surgery. And I would also tell them not to stop their routine medications, their anti-hypertensive medications and all that, because sometimes the anesthetist would tell them to stop to take anything orally, and they stop even their hypertensive medications. So I insist that they take their routine anti-hypertensive medications. Now, the physician and the cardiac evaluation is very important in relevant patients. Nasal examination, yes, is important, especially to rule out if there are any polyps, mass, or DNS, or generally the appearance of the mucosa. Anesthetic support, I depend on them. Yes, like Javed said, we have anesthetists 24 hours who are there with us. So I think we are a little more relaxed when they are there. They always tell us, like, don't panic, go ahead, do it. Even for our residents, when they are around, you feel a little more relaxed. Whether what they do, I leave it to them. They use all sort of concoctions to make sure that the BP drops down, and then we operate in peace. Positioning of the head is again important. Elevate the head end. Instruments or the armamentarium that I would, apart from our routine instruments that we have, I insist on good magnification. Have a loop, so you have to see what you're doing. Tiny things matter. A good headlight. I don't generally use the cautery much, but it is good to have them around, especially the fulguration mode when you don't know where exactly it is bleeding from. So when you use the fulguration, it generally gives the collateral burning as well. So your bleeding can, to a certain extent, be reduced, and a good suction apparatus. So a good endoscope, good set of instruments. You have retractors. Apart from all that, invest on very good punch. They should be sharp and good. I generally use the malt periosteal elevator. I like them. Good blade, scissor, and the surgical sponge, the Merocell or the non-woven sponges, they're very good in absorbing blood. So the surgical technique, again, nasal packing is very important. You have to pack where it is required and to the extent that it needs to reach the place where it is supposed to reach. So you can see the sac is here. So at least it should go to that level and not somewhere close by here at the ala of the nose and stop it, or don't go below. So careful surgery, again, I use 1 in 1000 adrenaline. Careful surgery is very, meticulous surgery is important. If you see most of us, most of the residents especially are, I don't know, they've got psyched up by this angular vein. It is not really, you don't really need to be very scared of this angular vein. If you see it, you simply retract it and it just stops bleeding. So just a small video on what I do. Off late, I have started, Off late, I have started inject, even for my endonasal, routine external DCRs, I do a little bit of endonasal injections. I give injections as well. So that kind of like, it arrests the bleeding much more. I'm happy that way that the the nasal mucosa doesn't bleed much. And not always it can be as roomy as this endoscope sometimes. And then visualize the packing. Where you need to pack is need to be visualized. And this is another patient where it is narrow, but still you can negotiate a needle and give an injection. So that kind of gives you you're sure that it is well taken care of. The same block, apart from that, I also inject transcutaneously into the sac. And so especially if the sac is a little inflamed, that helps. And the routine, all this I will skip, but there is one small tip that I need to give here. When you are separating the orbicularis fibers, hit the bone and separate the orbicularis fiber. And you can see that there is a small opening created. Go through the same opening. Don't go again with a new pass. That same pass, if you go, you tend to, hit the bone and then it separates out pretty well. And also, when you see that there is some kind of small feeder vessels would be there, if you look at that, bare the periosteum. This is again important. You see here, these are small feeder vessels which are here. So if they are there, I cauterize it. It makes your life a little more simpler. And the angular vein, you can see a plump angular vein, just retract it. It goes behind the retractor. Your assistant does a good job by holding it there and also giving the pressure. And when you retract the sac, it is important to retract it along with the periosteum. So that way your sac is protected and periosteum is avascular. So that zone is important. So if the sac is inflamed, and then your routine punching, the punching part I will take out. And once you do the punching, I think Akriti was also mentioning about injecting. Yeah. I inject a little bit into the, once the a meticulous sac flap is also important. And see here, so you have got the sac flap, which is relatively bloodless here. And this point, again, I inject into the nasal mucosa, the local anesthetic. And then at this point, if you want, you can pack a little more. And before you take the nasal flap, I again bulge the nasal mucosa with the bud. So that way you're protecting your middle turbinate there. So you don't inadvertently hit the middle turbinate. And you can see that it is a very gross enlarged middle turbinate. And then your routine, the rest of it is the same. You suture it and close it. So that is my small tip for preventing. And thank you very much.
Lovely talk, Shruti. Very thoroughly covered. Dr. Arvind?
Dr. Shruti, your compliments for such a nice video. The resolution, the clarity, the hemostasis, everything, and the bandwidth was perfect.
Thank you, Arvind. I think I should tell my residents, they do an excellent job by recording with their smartphone itself. Nothing fancy, just the smartphone.
Good.
Yeah. Is there anybody nowadays ever has torrential bleeding, or it doesn't happen at all?
I have had my share of bleeding. Yes, it can happen. Main problem that I have found is the intraoperative rise in the BP. So that is what I feel at that point. You know, you're panicking. Your patient can hear you panicking, and that is what is important, I feel. And that is when our anesthetists, they take over, and then somehow they do something and just reduce the BP, and then the job is well done.
Okay.
I use, as Javed said, I also use a lot of adrenaline. So I think that way it is quite all right. I pack with adrenaline. I inject again with xylocaine with adrenaline. Again, I give injection when I'm doing the nasal flap. So all that has helped me.
Do you? I noticed that when you took the nasal mucosal flap, there was no nasal pack. So do you remove it?
No. When I do that, I've removed in between there, but I always repack with the nasal mucosa, and then I bulge that so that there is something behind that. So when I take an incision, I don't hit anything, any vital structures behind, or just mainly the middle turbinate.
I'll just pass a question to Dr. Shreya Shah. Do you have any additional tips, madam, on hemostasis that you do?
Yeah, actually, Dr. Shruti showed a very nice external DCR, but what external DCR I am doing is I'm not opening, I'm not making any flaps. I'm still doing the old technique, which was power implantation, but slightly modified implant we have designed. So I just make an incision below the middle palpebral ligament, and already sac is inflated. So I know that my blade will definitely go into the sac. My another cannula is there into the sac through the lower canaliculus. So your blade and cannula touches, so you're sure that you are into the sac. Same way, I have done my study with 90% of success rate, which is cannula DCR, what we do for an emergency-based internal drainage of the sac, where you need to clear out the pus and everything into the nose, and you can proceed for other surgery. So that based on my knowledge of cannula DCR, I make it 45 degree. I do cannula DCR, I confirm on table where it is patent, then I just simply drill. So now drilling itself is, before drilling, I definitely inject again into the periosteum that Dr. Javed said, adrenaline and lidocaine. And then I just simply drain and we have our own device implant. I put that implant and there is no bleeding I have seen. Yeah, but sometime when blindly, if you are putting a blade, there is definitely angular vein cut, but don't worry about it. The moment you drain and you put the implant, it usually goes side, and simple pressure, what I have felt, that surgery usually I finish in 7 minutes, that to 4.5 millimeter incision.
I think we should have a video talk sometime for that.
I'll
Thank you for
definitely
that.
share the video with you. That is 4.5 millimeter incision on skin, and nothing, we don't have to do anything. It's as good as external DCR with implant, and I confirm all the implant through the nasal endoscope also, which is properly placed and cleaned. And sometimes it is plugged, then we have to clean in OPD with endoscope help.
I think our take home should be a thorough preoperative evaluation.
And what she, I'm sorry to interrupt, what she said, hypertension is definitely what Dr. Shruti said. When you are becoming panic and again that bleeding and again that hypertension, that is a vicious cycle. So that time, if you have to have not even anesthetist, but if your resident can do something to lower the BP, that definitely helps you.
And again,
Arvind, can I get a couple of points in, because the main reason why general ophthalmologists in most parts of the country do not do a DCR is bleeding, right? Most general ophthalmologists are trained in ophthalmology. They have done DCRs as residents, but someday they stop doing it because they come across a patient who has bled, and that's a nightmare situation. Ophthalmologists have a very, very low threshold for bleeding. It's lucky most of us don't faint at the sight of blood. When you compare us with ENT surgeons or plastic surgeons or orthopedic surgeons, blood all over, they maintain their cool. But ophthalmologists in general have a very low threshold for bleeding. So the main reason why general ophthalmologists do not do DCR and bring us oculoplastic surgeons in for these operations is bleeding. So I think it's important to emphasize that before you start DCR, you should be equipped. If you start bleeding and there are the things available are not enough for you to stop bleeding, that's when you panic. You can in fact even kill the patient theoretically in that rare event. So a good bipolar cautery, you can have a radio frequency cautery, a bipolar cautery. You must have something like Abgel, which helps you to arrest bleeding, or something like Surgicel. We'll not go into details, but if there's time for discussion, we can add those on. And increasingly, I have found that when I work on bigger areas and larger areas and bigger, apart from lacrimal surgery, fibrin glue available in most theaters. I think in multi-specialty hospitals, it's used widely by hepatology, neurosurgery. Ophthalmologists also use it mostly for pterygium surgery, but fibrin glue is also an absolute boon. In addition, with the advent of nasal endoscopy, we know where the blood is coming from. Compared to earlier when nobody knew nasal endoscopy, there's blood oozing through the nose, we don't know where it is coming from and how to deal with it. So today, the kind of torrential bleeding which panics an oculoplastic surgeon, I think is very, very rare. So once you're equipped with these and bone wax, very rarely used, but if your bone is bleeding, you can, nothing goes into that area, your cautery doesn't go, your Abgel is going to get washed out or come out. Bone wax applied forcefully gets into the little crevices in the bone from which bleeding is there. So if you have all these in your theater, then I think you can very boldly go ahead and almost never come up with serious bleeding. But I just have to put these points.
Yes, thank you very much, Dr. Ravindra Mohan, for your the very important words. Shall we go on to Dr. Vikas? He's going to tell us on another very important topic about mitomycin and DCR. So on to you, Dr. Vikas.
Good evening, everybody. And thank you, Dr. Chitra, for having me here. Can you see my, just one second. I'm able to share my screen. Can you go to the next talk first? Let me just come back to you.
Yeah.
Having some difficulty with Zoom.
Yeah.
Next speaker is Dr. Shivayogi.
Yeah. She's a founder and chairman of Usagar Eye and Skin Hospital, Davangere. Yes, Dr. Shivayogi. So we look forward to knowing a lot more from you about intubation and removal. On to you. Are you there?
Yeah, I'm very much.
Yes.
Is my slide visible?
Yes, yes, very much visible.
Yeah. At the outset, I would like to thank AOS, Dr. Chitra, for inviting me for this beautiful webinar on dacryology. First time in my lifetime I am attending a webinar or a conference on dacryology. Simply, we are tear wipers, isn't it? So whenever somebody asks, what are you doing? I just tell, I wipe the tears of the patients. Anyway, that was a very good and nice discussion, previous speakers. And my job is to speak on the intubation and removal and everyday practice. I practice in a place called Davangere, that is central Karnataka. It's around 4 hours from Bangalore. And most of my practice is lacrimal surgery. And I do exclusive oculoplasty since last 12 years in this place. So you all know that stents are small diameter tubes placed within the nasolacrimal system to maintain the patency. There are a lot of materials which were described earlier. And nowadays, the most commonly used material is silicone, as you all know. And silicone is being used in other subspecialties of ophthalmology also. This stenting is a temporary process, but in some cases, it might be kept for a long time also. This stenting is also used in laceration of the tear drainage system or any trauma to this tear drainage system. My practice here in my place, I use only 2 types of stents, that is the bicanalicular stent, that is the Crawford tube, and the monocanalicular stent, that is the miniature of a monocast stent, that is mini monocast stent. What is an ideal stent? An ideal stent should have all these properties. It should be inert, pliable, self-retaining. It should be smooth. It should have a smooth external surface so that you can stretch it. It should be easily available, and most important of all of these is it should be affordable to a common man, because people like me practice far away from Bangalore and the affordability is slightly less when compared to Bangalore. So as already I have told, we have bicanalicular and monocanalicular stent. So what is a bicanalicular stent? It's also called as Crawford's tube. The bicanalicular stents pass through both upper and lower canalicular system, creating a closed circuit. We should remember this. This is a closed circuit. They can intubate the upper, lower canaliculi connecting via the common canalicular system. They can also intubate the entire nasolacrimal drainage system, including the lacrimal sac, nasolacrimal duct, with circuit being either open or closed, as in this case when we intubate a child with a nasolacrimal duct obstruction. On the contrary, the monocanalicular stents intubate either the upper or the lower canaliculus, especially in trauma. In other case, like a surgical procedure, which can create a pathway of the stents to be placed directly into the nose, as in this case when it comes to Lester-Jones tube. As I previously told, I use mostly the Crawford stent, which is from the Orolab, that is Orolac, which I prefer. That is my stent of choice. I don't have any hesitation. It involves the entire nasolacrimal drainage system. It's a bicanalicular stent. It has a bulb. This is very, very important when you are purchasing bicanalicular stent. Always look for this bulb and the attachment here. So this attachment is very, very important, because whenever you pass, this might tear away. So this tube should be well over this aluminum foil, and it should be bulbous at the end so that you can easily pass into the canalicular system without causing any damage to the epithelium. Mind you, if you damage the canalicular epithelium, it's going to cause fibrosis in the future. So not much of a Rittling stent was designed by Dr. Rittling. This has a stellate. It's again a bicanalicular intubation, and once it is inside, the stellate is removed, and the one end of the bicanalicular stent is advanced through the hollow lumen of the tube, and it's repeated via the opposite punctum. Not much of use nowadays. Pigtail donut stent involves the upper and lower common canaliculi. It's a commonly used traumatic canalicular laceration repairs where patency of the nasolacrimal duct is intact. This is a recent stent which the FDA has approved in 2012. This is called canalicular flow stent. So this stent is made up of central thin intracanalicular portion, and this stent has a wing here, a couple of wings here and here. So what you have to introduce this through the upper canalicular system, and once you are into the common canaliculus, once you are towards the lacrimal sac area, then just withdraw this, holding this tube, and the same is repeated with the lower canalicular system. I don't have any experience with this. This is a new stent. If somebody has an experience, please kindly throw or enlighten us. What I would like to highlight is this is a GRU director which is designed by me. When I came out of Arvind, I was not getting a GRU director. So once when I was eating the ice cream, I saw this ice cream with this spoon. This is called Gadbad spoon. So what I've done is I've decapitated this spoon and bent a little here and smoothened this area, which acts as a GRU director, which is used for intubation of bicanalicular Crawford's tube. So this is the spoon which you can see in the nose, and the tube is being passed, and the metal rod which touches this spoon and comes out of the nose like this. So this I call it as modified GRU director. On the other hand, this is the mini Monaca stent, a miniature of the Monaca stent, which has a tail. This is the head and the neck of the mini Monaca stent. So it involves a single canaliculus. As I've already told, it's a silicon stent which is anchored at the punctum by a plug or a cap at one end. It's used to treat canalicular stenosis or canalicular laceration. So whenever there is a canalicular laceration, you have to pass this tube through the punctum, and this snugly fits into the punctum, and the other end passes through the cut end of the canalicular system. So this invention of this mini Monaca stent, or availability of mini Monaca stent in the Indian market, has totally changed the canalicular laceration or canalicular tear. If you can remember, in our resident times, we used to pass the IV Venflam into the lower canalicular system and try to tie it over the near the punctum area, and invariably it used to come out, and a lot of fuss with those Venflams and IV cannulas. So availability of this mini Monaca stent, again thanks to Aurolab, which is supplying Aurostent, and I use a lot of this in lower canalicular tear or upper canalicular tear. So Jones tube, again it's a Pyrex tube, a glass tube. Don't have much experience. When I finished my fellowship, did some 10 cases, and which I brought it from Arvind Hospital, asking Usha madam, and the results were not that good, and these tubes can be directly put through the carunculectomy wound and directly into the ostium. You can place this, and you can suture this end to the conjunctiva, and this goes into the osteotomy. So coming to the stent removal, this again, there are the techniques for stent removal depend on the type of stent utilized. Crawford stent, I tend to remove at 4 to 6 months. There are two approaches: endonasal approach and the open approach through the eye. You can remove endonasal through the endoscope. If you have any roti, just go into the nose and try to identify the knot and just cut it and remove it. It's easy. I mostly do the stent removal from the eye side, where I identify the stent and cut it and try to remove it through the nose. So this is a office procedure, OPD procedure, and try to remove. I'll try to remove after 4 to 6 months. So most of my, in my experience, if you ask me, if I do around 10 failed DCR, so in my experience, in this part I'm talking about, so 8 of the failed DCRs, they are like a primary DCRs to me. I mean, when I open, the MCT is intact, and the bone is intact, everything is intact. So roughly around 70 to 80%, they are like primary DCRs to me. Around 2%, you can say, or 20% are when I use these stents. I don't use in all failed DCRs. I try to use stent in facial fractures when the patient comes with a fracture, or when I feel the common canalicular area is fibrous because of previous surgery. So in those cases, I would like to use stent along with Mitomycin C. Mini-Monaco stents are removed by grasping the header and pulling it out from the punctum. It's again an office procedure. Ritlings are removed again in the similar fashion as the Crawford stents. The canalicular lacrimal flow stent is removed by simply pulling the export stents, and the Jones tube, usually we try not to remove it, but again you have to cut the suture and you have to remove it if you want to remove it. So this is a video. I don't think, yeah, this is a small video where I'm removing the Oro stent, that is Mini-Monaco stent. Coming to the complications of stenting, prolapse of the stent. This is a very common complication when my resident calls me, sir, case has come with prolapse. So this prolapse can be managed. The small prolapse can be managed. Just try to put it using a tooth forceps, try to put them inside. This goes inside and then anchor the knot in the nose. Whereas if you have a large prolapse like this, so you need to check the knot through the nose and bring it back and then suture it. So that is one complication. You have some complications like this when there is a foreign body granuloma like this. You cut and remove, again there is a granuloma. So in that case, you have to remove this by canalicular intubation. Sometimes there might be damage to the puncta when you have excess tension and there is cheese wiring of the puncta. Granuloma we have already discussed, and infection of the nasolacrimal drainage system reported in some literature because of contamination of the intubation with organisms such as non-tuberculous mycobacteria. In summary, stents indicated in punctal and canalicular stenosis, they restore normal epithelial lining and prevent a reclosure. And everyone should have thorough knowledge about the mechanism and design is essential in choosing appropriate stenting. Thank you.
Thank you very much, Doctor. I mean, I found it very interesting. I don't know what all of you are pretty familiar with it. You said about the extrusion of the stent. Could there be any choking experience rarely?
The patient coming with choking, you mean?
Because it's gone behind?
No. It's not in the throat or in the respiratory tract. It has just gone back in the mucosa itself. So the patient doesn't have choking, but I have some patient who have swallowed it.
Yes.
Yeah.
Yes, Dr. Arvind.
In view of time, I'm just going to ask a quick question to Dr. Javed. I know your work on biofilms and removing all these stents. Is there a scientific study or a period of time for which these stents should be retained? Because I think we all agree on the indications, but when we remove the stent, it is dependent on a very subjective scale. So do you have a time frame for removal of the stents?
Usually the biofilms on lacrimal stents start developing by 4 weeks and they get well established by 6 weeks. So I usually don't use beyond 4 weeks for routine DCRs, and for a regular canalicular thing, especially those cases with ICID or recurrent ICID or complicated kind of cases, I keep it at the most for 6 weeks. In the rare event, if I have to reuse it, I remove it and place it a new one back. Because what happens is that the biofilms then starts mounting an immune reaction to the host tissues, which is what we don't want. We don't want inflammation in those tissues, because then when you remove the stents, there's a very good chance of reocclusions. So 4 to 6 weeks is the usual time, but then it's individualistic. When I was, as a fellow, we used to place it for 3 months at that time when we were with Dr. Honawar. But that practice does not have evidence base. Evidence-based practice says 4 weeks as of now.
And Dr. Javed, you also worked on assessing the ostium, and serial assessment of the ostium shows that it doesn't reduce in size any more beyond 4 to 6 weeks.
Yeah. So what happens is that the epithelialization usually completes by 1 week of the DCR ostium. So, and then there's a little shrinkage that happens by 3 weeks, and beyond 4 weeks, serial assessment up to 2 years have not shown any change. And then we also looked at rabbit models where we created rabbit models of canalicular injury. And when we studied histopathologically so we did canalicular nice cuts, just like a canalicular injury. And when we looked at the stents, we found that most of those canaliculi heal by the end of 2nd week. So again, 4 weeks can be a safe margin, even if it's a canalicular laceration.
Thank you very much. A lot of information. We shall now go on to our next speaker, Dr. Dipti, who is an oculoplastic and orbit specialist from Divya Drishti Eye Care Hospital Center, Mumbai. And she is going to tell us something, a freelancer's view when these aspects are considered.
Good evening, everyone. So I would like to, am I audible?
Yes, yes.
So I would like to thank Chitra ma'am, Arvind sir, and Vidya ma'am for giving me this opportunity today. So my topic is completely non-academic. It's my own perspective and my own personal experience per se as an oculoplasty, freelancing oculoplasty surgeon. I'm sure there are many here and they would have a different opinion as well. So I would just share is my presentation visible?
Yeah. We should have heard Dr. Vikas Menon, we missed out. Yeah.
Oh, sure. I should continue or?
No, you continue. After that, we'll go back to him.
Okay. So I finished my fellowship from Arvinda Hospital, Madurai, and I came back to Mumbai. That's my hometown in 2014. And when I came back, there was a very different practice pattern which I saw when I came to a metropolitan like Mumbai. There are many private practitioners in Mumbai than the institute, like dedicated ophthal institutes, how we have in South India. And whatever institutes or tertiary higher care centers are there, they are already occupied. In Mumbai or any, I think, metropolitan city, the doctor to patient ratio is also quite high. So what I faced was there was a significant time lag for getting the first attachment or a first surgery when you're fresh out of a fellowship, when you're fresh into a practice, minimum 6 months. So then there are trust hospitals or peripheral centers in the cities where you can get an attachment for starting your oculoplasty practice per se. And what I would advise is actually have one multi-speciality attachment, because being an oculoplasty surgery or being a DCR, you need to have that backup for shifting your patient, or for oculoplasty orbit surgeries, you need to have that backup of a multi-speciality. So these are the things which I learned over a period of time to carry with me always. The own autoclaved set of instruments in a sterile instrument in a drum, because you may not be comfortable with somebody else's instrument. Then most of the places, the assistant which you will get is the one who's trained only to assist cataract. They don't have much idea about DCR or oculoplasty procedures, and they don't know how to make nasal packs. So I always carry my own nasal pack, sutures, 60 Vicryl and 60 Epsilon. I always carry bicanalicular stent, because you never know whom you will have to do it for. And if I have been informed before, if it's a failed DCR or any complicated DCR, then I always carry Mitomycin C as well with me. And I carry Surgicel packs. So Surgicels are nothing but a bioabsorbable thrombogenic cellulose sheet, which will help you in arresting the bleeding. I have certain preoperative protocol devised over a period of time after many experiences. So general ophthalmologists, they just do a cataract related investigation, but we have to insist them to do a coagulation profile, ask for the history of blood thinners, and get blood group cross-match as a standby protocol for all the patients. I give this preoperative medicine as to all my patients, topical and oral antibiotics 1 day before. Then recently I have been advised by some anesthetists, so I have started giving patients oral tranexamic acid as well, 500 milligram TDS 1 day before. Then I start patient on nasal decongestant like oxymetazoline also 1 day before, and I do give oral anxiolytic, Restil or Anxit 0.25 milligram 1 day before. Now, basic question is, how do you carry your instruments, or what do you do about autoclaving sterility? So there are two options. When I was new into the practice, I didn't have my own setup or anything else. So you either have to drop off your instruments to the place where you have to operate. So that's the travel time you save, and or else you have some trust hospital attachment or some hospital where you can get your set autoclaved. Second is, best thing is to have your own setup where you can autoclave whenever you want, and then you carry the sterile set in a drum. Being a freelancer, what you face is a variable size of OTs, variable presentation of OTs, where the table trolley is microscope is usually arranged as per the parent surgeon, who's usually a cataract surgeon according to their preference. So you have to spend some time initially to do that setup. The anesthetist backup has to be there. You have to insist on that. And since you are not the one who has checked the patient before, so you have to do a sac patency test and a probing before you take a patient for surgery. So these are just a few pictures to show how I do my arrangement of OT for DCR. I usually keep the OT trolley where the instruments are there at the head end. The assistant is on one side, opposite side, and I sit on the side of the surgery. And many places, maximum places, I do not have an overhead light source. So I use this microscope. I tilt the head in a way that the light falls in my operative area. And yes, it does give a lot of neck strain. Other option is this portable light source, which if you have an attachment where you do more regular cases, you can insist them to invest into this. Or you buy a loop with a light source. Now, I would like to talk about some pros and cons of freelancing. About pros, that freelancing doesn't require any investment per se. You have to just buy your own instruments, sutures, and everything. The post-op, pre-op evaluation, everything is taken care by the parent surgeon. So you are not investing too much time on that. You get flexible working hours. You can have your own rules and your own timing decided. Then sitting at one place in a one OPD doesn't get you more exposure to cases. The patients are not oculoplasty or DCR patients are not simply going to walk into your OPD. So you get more variety and more number of surgeries if you are in a freelancing setup. And you also develop a networking among your peers. That is how you get references. You meet more people, you meet new anesthetists, and it just expands your world. Now, cons of freelancing are like, as I said, you are not at all much in contact with the patient. It's never your patient per se. So you don't have that patient-doctor relationship. Then it's a time-consuming process to do the OT arrangement and entire setup. It's not like how you would have in an institute where everything is ready, and it takes time to start a case. Then there is a time lag to have an established fixed attachment. You are easily replaceable, obviously, and traveling time, especially in Mumbai, the expenses we have to account for, and definitely it has lower income potential. So this is my own perspective and my own experience, which I shared. We can discuss about it. I would like to thank you all for the attention. Thank you.
Dr. Deepthi, that was a wonderful talk.
Yes.
Purely because I totally understand your pain.
Yeah. No,
Very
I
honest.
also felt she's a very courageous, smart girl. You know, there's a lot of hardship into all this. And, you know, if you're very confident about your content and your surgical skill, I think an oculoplasty surgeon will find himself anywhere. Very good. Very nice.
Thank you, ma'am.
I think paucity of time, we have to move on back to Dr. Vikas Menon, and let's hear about what he has to say about Mitomycin C DCR.
Hi, good evening, everybody. Can you see my slides? Hello?
Yes, Dr. Vikas, we can see your slides. Please go ahead.
Okay, so how do I go to that? Just a moment. Yeah. Yes. So I'll be talking about Mitomycin C in DCR. First disclaimer is that whatever I'm going to say is extensively copied from Dr. Javed and Dr. Akshay's work, and I know they're nice chaps, so hopefully they won't mind. So from all the preceding lectures, what we have understood is that DCR is a major surgery. It is in no way a minor surgery for which you have to really prepare a lot. Pre-op evaluation, a lot of systemic evaluation you do, and then you have to struggle to maintain hemostasis during the surgery also. And patient also has to undergo some pain under local, or has to undergo GA procedure. And what happens if subsequently that procedure fails? Now that is something really painful for the surgeon as well as the patient. And that's really very unpleasant for all the parties involved in this. So we know that, DCR failure happens most commonly because of the blockage of ostium that we have created. Now, what causes the blockage of that ostium is granulation tissue or scarring. That's basically the body's own response itself to the trauma that it has undergone during surgery. And also, many a times, if our technique is also not, up to the mark, then sometimes we end up injuring the nasal septum, nasal mucosa in certain ways, or maybe using more of cautery and causing more of necrosis and leading to adhesions or synechiae in the nasal cavity, which can also contribute to the failure of our procedure. And the reported failure rate has been documented to be about 0 to 18%, both external and endonasal route. Again, quoting from Javed and Akshay's work. So we all, as ophthalmologists, have been exposed to using Mitomycin C for a long time. We've seen our seniors and a lot of older glaucoma surgeons use it in TRAB for a long time. And nowadays, corneal surgeons are also frequently using it. And we have also now been using Mitomycin C for a long time in DCR. We know that it's a systemic antibiotic which is derived from the filamentous bacteria Streptomyces cespitosus. And what basically it does is it targets fibroblasts. So fibroblasts, as we know, that are the key cells involved in causing scarring and closure of the ostium. So here we have an agent which acts on these fibroblasts and inhibits the synthesis of proteins and inhibits the synthesis of collagen by fibroblasts through various ways. And then it inhibits fibrous tissue growth and scarring in the ostium. The advantage of this drug is that it's a fairly cheap drug. You get it for almost about 200 rupees, and you can dilute it in normal saline, and you can even store it in at room temperature for up to 48 hours, and it remains stable. So that is another quality, that even in economically challenged situations, you can still go ahead and use it. And there is plenty of evidence. There is plenty of evidence which points towards the utility of mitomycin C during DCR surgery. And there have been randomized control trials. There have been various meta-analysis. And so you just have to type mitomycin C in DCR in PubMed and you will come to know of the large number of studies which have already been done. So there is no excuse nowadays to not use this drug. It's been proven that, it is useful. And there has been no study so far which has shown that, any disadvantage of using it. Any study which shows that the success rate has gone down after using mitomycin C. So that has not been the case. It has always, in whatever studies we have come across, it has shown to increase the patency of the ostium or increase the chances of the ostium being patent. So another question was, what is the ideal dose and for how long should we keep it in place? Right. Now, again, Dr. Javed has solved that problem for us. So he conducted a basic study on fibroblasts of nasal mucosa and found that any dose which is more than 0.5 milligram per ml is lethal and causes extensive cell death, or any concentration more than even up to 0.4 milligram per ml, but if used for more than 5 ml for more than 5 minutes, can cause extensive cell death. Now, what happens is if there are more cell death, what will happen? There will be more tissue necrosis, there will be more subsequent fibrosis, and there will be more irregular healing, which can impact your ostium. And they also found that the minimum effective concentration seems to be 0.2 milligram per ml for 3 minutes. So what I use at present is 0.4 milligram per ml for 3 minutes. That is well under 5 minutes in adults. And for pediatric cases, I use 0.2 milligram per ml for 3 minutes. So this is my preference, but Javed has shown that 0.2 milligram per ml is also good enough. This is just a brief video for people who may be wondering that, who heard about mitomycin but wondering how to use it. So you take these sponges, these Merocell sponges which come, and you insufflate them with mitomycin C. 0.1 to 0.2 ml will go into one of these. You take 2 of them, and when you are at the stage where you have created the flaps, the sac and the nasal mucosal flaps, you created the ostium. So you put one by one these 2 Merocell sponges in the ostium, right? And you make sure that your flaps are lying over the sponges, and then you leave it in place for about 3 minutes. That's it. Once 3 minutes are over, you retrieve your sponges and then you irrigate the area with normal saline and you wash it properly. I also tend to wash the skin wound also properly after using mitomycin, just in case, there is some delayed healing or something. And some surgeons are there who do not prefer to irrigate also, but that also seems to be working fine. So that's an individual choice probably. And then you just close your flaps over it and the skin and orbicularis the usual way. So that is how you apply mitomycin C in your ostium. It's pretty straightforward, simple technique.
1 minute left.
Okay. The other described methods which have been described are circumostial injections. Again, Dr. Javed, I will quote here, who has described circumostial injections in certain situations where he feels that, there is chances of more scarring. So you inject mitomycin directly into the nasal mucosa and you can repeat those injections also subsequently. So he's found that, that the results are superior. There have been reports of 2-stage application of mitomycin C, one intra-op and another application subsequently at week 1, 2, or 3 with the pledget, cotton pledget into the nose endoscopically, and that has improved the situation. Some surgeons have described post-op MMC soap nasal packs for about 24 hours. So there have been different ways in which mitomycin C has been described. So what do you do is actually up to you, but one thing is clear that using mitomycin C in some form helps to improve the efficacy of your DCR. It helps to prevent closure of the ostium. Talking at the end about contraindications and side effects. So to date, there have been no direct complications which have been associated with the use of the dose of mitomycin C that we use in DCR surgeries. And whatever contraindications we know are from the systemic literature. If there is a history of hypersensitivity reaction to any drug, you don't use that drug. That is basic. And patients with high serum creatinine, you don't use mitomycin C. Coagulopathies, bleeding diathesis, we prefer to avoid. Severe immunosuppression, you avoid. Now, again, this is again related to the systemic dose, which is very high when used in cancers as an anti-cancer drug, but better to avoid. Why to take a chance in such cases? And also in pregnancy and ladies who are breastfeeding, so you avoid using Mitomycin C, as it is not recommended for pregnant women and for feeding women as well. So to conclude, it is a well-proven adjunct to surgery, and all DCR surgeons should be familiar with using this useful medication in most, if not all cases. So I specifically did not put any slide for indications of Mitomycin C because for me, I use Mitomycin C in all my DCRs. So there is no specific indication, but if somebody were to pick out few indications, then obviously pediatric group, post-trauma group, and anywhere where you, or a failed DCR, wherever you are anticipating more scarring, you could go with them if you are going to use it selectively. But if it's a major surgery, patient is coming to you one time and the repeat surgery does not have that good an outcome. So why not give our best to the patient in the first go itself? That is the whole point. Thank you very much.
Thank you very much. Have you had any problem by use of Mitomycin in the surgical site, like, in a glaucoma surgery, the blood can become very cystic and all that. Of course, there are other reasons also for being cystic. Now that you place the pledget posteriorly in glaucoma surgery, we don't get those kind of cystic blood. So that way, is there anything of practical tip about Mitomycin? Nothing at all?
No, we haven't had any problems with using Mitomycin C for 3 minutes whenever we are using in ostium. So far, there hasn't been any problem.
Okay, right. Thank you. Dr. Arvind, you could stop sharing. Wonderful talk. Very crisp and relevant.
Thank you.
Actually, there are a lot of questions I'm sure we want to ask about Mitomycin because it's a really new concept. And I think all the articles are all cited to Dr. Javed. But in view of time, I think we have 3 more speakers and we have little time. So we'll proceed with the next talk, madam.
Yeah. So we shall now go on to our next speaker, Dr. Akshay Nair, a very dynamic, prolific oculoplasty surgeon who's specialized in cosmetic oculoplasty, ocular oncology, facial aesthetic, and ophthalmic plastic surgery. And he is presently practicing at Advanced Eye Hospital Institute, which is part of Agarwal Group, collaborated with the Agarwal Group of Hospitals. Am I right, Dr. Akshay?
Yes, ma'am. We are all fortunately, unfortunately, all the 3 hospitals that I work at are now all a part of the Agarwal's group of hospitals.
Okay, very nice. And I have heard him talk in earlier ARC webinars, and I really look forward to a lot of learning which will come through. On to you.
Thank you so much. And I think I'm honored and privileged to be speaking on the same platform as my mentor, the teacher who taught me every lacrimal surgery I know, Dr. Javed Ali. So the aim of this talk and the target that it is, the target audience is practicing oculoplastic surgeons or even fellows and residents. External DCR is taught and practiced in day-to-day oculoplastic practice. So I hope that by listening to this talk, we can ask ourselves, those who are not yet doing endoscopic DCRs, is should I start doing endoscopic DCRs? Possibly, can I start doing endoscopic DCRs? And hopefully, by the end of this talk, you can ask yourself, how do I start actually doing it? Because that is what I'll be trying to explain. So in a way, this is a blueprint for how to take the leap from endoscopic to external to endoscopic DCR. So before you decide, there are multiple things that you need to have within your reach available to you, and also a few things that you need to take into consideration before planning to actually offer this surgery to your patients. The hardware, the instruments, the economics, and how to maximize outcomes in this surgery. So before even ending up to buying an endoscopic DCR equipment, you need the skill set to start doing endoscopic DCRs. So there are 2 ways you can do this. Either you get the endoscopic DCR and start doing it or learning it and practicing endoscopy before you actually end up doing endoscopic surgeries, or you try to get the skills, everything except actually doing the surgery before you start doing it. In the sense, you undergo an observership, go see other surgeons doing it, possibly attend cadaveric workshops, and then come back and start buying it, then get your endoscopic equipment and do it. So how one way of doing it, or at least the way that I built upon my endoscopic skills, was getting the endoscope and start doing endoscopy in the OPD, in the OR for probing cases, for simple NLD probings. Or once you made the ostium in an external DCR, remove the pack, put in an endoscope, have a look at what the anatomy is, have a look at where the ostium should be. Or in your tube removals in the OPD, you can just visualize where the tube is or where your stent is. Or like was mentioned by the previous speaker, stent prolapse. The best way to manage a stent prolapse, put in an endoscope with a long forceps, just gently prolapse the tail of the stent back into the nasal cavity. So pre-op endoscopic evaluations, post-op endoscopic evaluation. Remember, the most important thing about an endoscopic DCR is not actually the DCR, it's the hand-eye coordination and the ergonomics of being able to look up at the screen and operate with both eyes, both hands holding two different instruments at different points. There are multiple cadaveric courses that offer you real cadaveric experience on endoscopic surgeries, on external DCRs, on every procedure. You can look them up online. You can find good courses in India and abroad where you can master these, the skills required. And this is only not just from the ophthalmic domain, even the ENT domain. So before you jump, you need to maximize what you have in your OR. Like Deepthi mentioned, a lot of factors that will not usually be discussed, such as the space or the area that you have. Most oculoplastic surgeons may also be doing cataract and refractive surgery, or they may have small ORs which may not allow them to put in a lot of instruments. So you need to be able to maximize or optimize whether you will be able to get in your endoscopic equipment in the OT as well. Small things like whether you have plug points or UPS that can support the electricity load of an endoscopic equipment. For a beginner, always prefer GA for endoscopic surgeries before starting to do them on LA. Remember, the surgeon comfort in the ergonomics, the equipment, the instrument, the anesthetist is as important as patient comfort as a beginner. For a beginner, you need to be comfortable completely. Only then will you be able to give the optimal outcome to your patients. Then have a look at the outcomes. So when we talk about an endoscope, this is the endoscope that we use. There are three parts. There's the camera head, which you can see. There's the fiber optic cable, which is attached to a light source that brings the light at the end of the endoscope. So each of these equipment, these three components of your endoscopic and your endoscope are separately bought. This is a camera head, which is the attachment for all endoscopes. It's a soakable camera head. It can either, the high-end ones have high-def CCD chips with multiple buttons that allow you to start recording, for image adjustment, for window adjustment. They can even have digital zoom. What you need to see is the compatibility with endoscopes. Just like if you're going to buy a phaco handpiece, you want to make sure that your phaco tip is compatible with the machine that you're buying, because one, you can't buy, say, of one company and you expect it to work on the other. You need to make sure they're compatible with all endoscopes. The next thing, which is the most crucial part, is your fiber optic cable. Prefer a standard company. They are expensive, but they are worth it. These are autoclavable. And like I said, you need to see whether they are compatible. Typically, fiber optic cables have a standard male-female outlet, which means they are compatible with all companies. And finally, the endoscopes. We prefer to use rigid endoscopes that have a scratch-free sapphire lens objective at the end. They are available in different sizes, either 2.4 mm, 2.7 mm, 4 mm, multiple sizes based on the diameter that you need to use. In pediatric endoscopic equipment, you might want to use small diameters. In adult, you can use a 4 mm diameter or larger ones. The angulation, as you can see from the side, it can either be an end-on flat 0 or even a 30-degree angulation. These are also autoclavable. And as is for most ophthalmic or any surgical equipment, you may also have third-party vendors which are compatible with a standard company. So, and they of course offer the equipment for a cheaper cost. So you should always check, especially if you're buying from a third-party vendor, whether it is compatible with your endoscopic handpiece, with your camera head or not. And finally, your light source. So when you talk about light source, there are two types. There is a halogen light source or the LED light source. Now, the halogen light source is cheaper. The life cycle, however, is much shorter. And you can see in this graph, the operating life for each lamp is about 300 hours. But whereas that for an LED is much more. So while your recurring costs for the halogen may be higher, your initial cost for the halogen may be lower, your recurring costs are much higher. So based on your usage or your expected usage in the future, make a choice on what you want to buy. Now you've got the endoscope with your camera head with the endoscope, your fiber optic cable with a light source. All of this, especially your camera head wire, goes into the camera system, which is basically the image processing units, which connects and shows up what you see on the endoscope on the large screen. It can either be an HD or a standard processing unit. Some of them allow you to only record still images. Some of them allow you to record movies. Sometimes you can get a combined, the standard companies allow both a camera unit as well as a light source combined into one. Some of them offer you separate, so you are able to customize them. Now, this is what a standard endoscopic suite from Karl Storz, which is probably the industry leader in endoscopic equipment along with Olympus. So you can either go for a HD equipment or standard. Based on the size of your OR, your screen, you can decide what you want. Portability is another issue. Now, that tiny little thing that you see on the right side, that image, is basically what is called Storz Telepack X. It's an expensive bit of equipment, but it's portable. That has everything. That has the screen, the camera image processing unit, as well as the light source, all built into one, and it fits in a briefcase that you can carry around. The latest model of Telepack, which is what the model is, has an HD screen. And not many people know, but close to the first 100 DCRs, endoscopic DCRs that Dr. Javed did was on a similar Telepack X that he got at LVPI. And he used to shuttle that as fellows from the OP to the OR. And even my first endoscopic DCR was done on that. So, if cost is an issue and you also want portability to fit into the role of a freelancer that Dr. Deepti mentioned, maybe this is what you need to think of getting.
1 minute.
And then you have the separate set of instruments. Now, endoscopic instruments obviously are different. You need your long forceps, which are usually the Blakesley forceps. You've got different serrated ones. You've got flat-tipped ones. Your forward biting punch, your backward biting punch. A suction elevator is actually an instrument that I even end up using sometimes in an external DCR, which basically has a suction tip, but has an opening at the tip of it. And it is hollow inside and can be attached to a suction cannula, which basically allows you to elevate the periosteum or elevate or retract soft tissue while constantly doing suctioning. So it clears your field as you go ahead and do it. A ballpoint probe and a sickle knife are very, very useful instruments, as are some instruments that you can borrow from your neighboring cataract surgeon, which is viscoelastics, and a crescent knife, which I use to open up the lacrimal sac. Fill up the lacrimal sac with viscoelastic and then open it up. So once you've got the hardware and the skills, then you have to look at the economics of how much does getting all this hardware really cost. Top of the line is Stryker and Karl Storz, which can go up to 25 lakh rupees. But if you need to go for basic starting equipment, you can get a basic screen with a camera and illumination system, a rigid endoscope, for close to $1.5 lakh. Indian equipment can be mix and match up to 4.5, 5 lakhs. Your additional surgical instruments can be up to $1 lakh. So in general, to get going and hit the road running, for value for money, endoscopic equipment and instruments which are of decent quality, Indian made, will push you back by about 5 lakh rupees. Additionally, you may want to get drills. Drills can be of good quality because remember, as oculoplastic surgeons, most of us already have drills that we use for our decompressions and orbitotomies. So at the end of it, like I said, you need to optimize. You can use the same endoscope for probings, for OPD procedures. In the beginning, you may want to have an ENT surgeon whom you can visit and watch some cases. And you should always maintain a good friendship with an adrenaline-friendly anesthetic who doesn't mind you going a little overboard with anesthesia, because the biggest concern that a beginner endoscopic surgeon can happen is the moment there is a little bit of bleeding or you touch a mucosal surface at the wrong angle, your view gets obscured. So you need to come back again, dip it in Savlon, clear the screen, check your white balance and go back in. You end up doing this about 30, 40 times in a surgery, it can get on your nerves. So if you've got a really good avascular field, it is very, very useful in reducing the surgical time as well. You already have wireless Bluetooth enabled endoscopes. You already have endoscopes that can be attached to a mobile phone and allow you to do this in your OPD and record the images on your phone. So learning the on the job is not new in ophthalmology. You think of the Doyens in retina surgery, in cornea surgery, the Natrajans, the Samar Basaks. They didn't have vitrectomy and lamellar DSECs and DMECs when they did their training and came into practice. They learned all of this on the job. OCTs in regular ophthalmology is a phenomenon that we saw only in the early 2000s. Before 2000, there was no OCT machines. And yet, bulk of the retinal practice nowadays is intra-VEGFs based on OCT and OCT angio. How do retinal surgeons who've learned more than 20 years ago adapt, transform their surgical skills, and now make it the mainstream on which their livelihood is based on? They learned on the job. So don't be afraid. Remember, endoscopic route is the future, because as patients get more savvy, more tech savvy, they read more about surgeries, they choose their doctors accordingly, and literature is now going to show you that endoscopic has equal, if not better, results than routine DCR. They're going to choose a surgeon who's more adept at endoscopic DCR, which is why it's better now than later. And I may have discussed the economics of how you can start with the basic equipment. Eventually, you need to upgrade yourself for the best, because as you do more, your skill will polish itself and it will pay for itself. Do it now to get the earlier bird advantage later on. So no longer do you have to tell a patient, I can't do it, and you need to go and do the endoscopic DCR from an ENT surgeon. With that, I'll wrap up, but not without taking your time to invite all of you all for the annual conference of the Oculoplastics Association of India. I'm privileged to be one of the organizing secretaries in Mumbai. It's 11th to 13th November. The early bird registration and abstract submission ends on September 15th. This is our first in-person meeting in 4 years. So please make it a point to travel to Bombay and be there. We'll be happy to host you and make it a great meeting. Thank you so much.
That was a wonderful talk. Actually, it should have been a debating talk, but I think why we did not make it a debate was people would have lost badly to you. That was so convincing a talk of yours. So we shall, thank you. Shall we go on to our next speaker?
Yes, madam. I don't think Akshay has left any room for any questions.
Yeah.
So,
We shall now go on to
Thank you,
Dr.
ma'am.
Marian Pauly, who's a senior consultant and head of oculoplasty, orbit, ocular oncology, and prosthesis from Giridhar Eye Institute based at Kochi. And she is going to talk on another, I don't know whether it's controversial, but another very interesting way to look at it, a bilateral external DCR, her views. On to you.
Thank you, madam. Thank you, Dr. Chitra, for giving me this opportunity. Let me share my screen. So I hope my slides are visible. So I'm going to speak about a little controversial topic. So bilateral simultaneous external DCR, my views. As we have already listened to all the previous speakers. DCR is the gold standard and the success rate is around 90 to 95%, even more than that, like almost 99%. And the incidence of bilateral nasolacrimal duct obstruction is around 9 to 18%. And even in bilateral cases, nowadays the surgery is done unilaterally. Even in bilateral cases, the main concern is bleeding, which we have already discussed. So we did a small study like 3-4 years back. Our hospital, this is my hospital experience, and we divided the success rate into functional success and anatomical success. So the age group was around 5 to 81 years. The mean age was 51.1. 3 patients had congenital and rest were acquired. Follow-up was around more than 2 years, like 25.8 months. 4 patients underwent surgery under general anesthesia. That was 3 kids, 3 children and 1 adult. The main duration of anesthesia and surgery is around 85 minutes. 1 patient had a bleeding. Intubation was done in around 40.6% of eyes. So almost anatomical success obtained in 87.5% and functional success obtained in 93.7%. So now what are the concerns in bilateral simultaneous external DCR? One is the amount of time taken. Second is the risk of complications. And third, whether it will compromise the surgical success. So what is the literature says? So in a normal condition, the surgery is brief surgery that is taking less than an hour. According to Tarbet and Custer et al., they took the mean duration was 53 minutes and Malhotra et al. Took 41 minutes. So when you compare the literature, SEC et al. Published in 2007, they took a mean duration of 89 minutes. Yüksel et al. In 2015, 86 minutes. Whereas he did bilateral endonasal endoscopic, it was 44 minutes. In our study, it was 85 minutes. So the time was almost comparable. But if you see one eye, it will take 53. That means 2 eyes will be more than 100 minutes. Malhotra et al. Took 41 minutes for one eye. So it's almost comparable. So in tips in bilateral DCR, you should not block both eyes together. Always block sequentially. Suppose block one eye first, then do the surgery midway. That is, after the punch, you can block the other eye. Similarly, don't pack both eyes, both noses together. Pack nasal pack is also sequentially. And after finishing the one eye, we have to, during the first eye surgery, if possible, cauterize the edge of the posterior flap, or you can suture the posterior flap so that it minimizes bleeding, as well as you need not pack the eye. So what are the advantages for bilateral surgeries? One is short operation time, low medication usage, especially painkillers, even antibiotics also. Hospital cost is also less, fast recovery, and the absence of stress from a second surgery. So in our study, what was the success rate? It was around 87.5%. So comparing to the other studies, it was like little less compared to the previous studies. So in fact, when we analyzed our cases, more than 50% of patients were using anti-glaucoma medications. It has already been reported that topical anti-glaucoma therapy as the risk factor for nasal aqueduct obstruction in AGO 2008 by Seaver et al. So it can be a causative factor for NLDO, or it can be a risk factor for failure in DCR. We know the pathology is mostly, especially in primary acquired NLDOs, inflammation, and anti-glaucoma medications can cause chronic irritation of lacrimal mucosa if they are not doing punctal occlusion. In our series, 2 patients failed. Actually, first patient was using 4 anti-glaucoma medications. Second patient was on 3 drugs. This was a little controversial topic regarding anti-glaucoma medications. So in my view, simultaneous bilateral external DCR can be done with a great success, both in adults and in children. And simultaneous surgery is always of both medical, economic, and social advantages. It can be either external or endoscopic. So thank you so much. These are my views. Thank you.
Thank you. Dr. Arvind, do you have any question to take before we move on to our last speaker?
This is always a preferred topic. We do both sides when the patient has a bilateral pathology. But I think ideal patient selection and eventually what you are comfortable with makes all the difference. In fact, I think I would like to ask doubts, but let's just finish Madam's talk, and if you have time for discussion, come back. Thank you.
So we shall now go on to Dr. Lakshmi, who's going to tell us something very, very relevant: failed DCR, evaluation and management. On to you, Doctor.
Thank you, Dr. Chitra. Can you see my screen?
Yeah.
Thank you for organizing such a useful and wonderful webinar, and Dr. Arvind for beautifully moderating the whole show. There's so much to learn and there's so much more to tell, but let me tell you that each and every single speaker has answered most of what I'm really going to mention. Possible causes are very many: previous of failed DCR, previous sinonasal surgery, they might have had FES surgeries, failed probings, mid-phase trauma, tumors, patients uncooperative to a proper clinical evaluation. So you really don't know what's happening. You're assessing the patient on the table, which is not good, anatomical variations, and you're not very sure as to why the epiphora started at all. Now there are various causes, congenital, it's very clear, probing and massage works 90% or more, and the few cases which need DCR, make sure that they don't go in for an abscess formation. And if there's an abscess, it's better to admit the child, give intravenous, and treat just as you would for an orbital cellulitis. So good technique of probing and syringing using an infant nasogastric tube to retrieve the fluid, or even those small tips for during anesthesia where you keep the head little lower down, make sure as much doesn't go into the passages, throat, etc. And the proper knowledge of the anatomy is most important. This is a child who had a stenting in the US with probing. I don't believe in fracture of the inferior turbinate. It is causing more trauma to a problem which is already existing. They were not sure whether the stent was there or not. So here CT-DCG, I cannot overemphasize, plays a very valuable role in delineating what is exactly happening, because 2 or 3 failed probings, the parents are very anxious. You don't want to land up in trouble. So know what is really happening before you go for a DCR or a revised DCR. Tip 2, we started wearing masks with shields long ago, many years back. And with COVID now, all the more the reason why you should wear. Thorough clinical evaluation is a must. Thorough anatomy and ENT evaluation. In each and every single case, I get ENT evaluation. This is my tip number 3. So failed DCR, usually it is sinusitis which has not been picked up. See, you are making a beautiful passage, as Shruti Tara beautiful showed an external. If the milieu inside the nose is no good, what's the point in making a good ostium? So get a good imaging done, and if there is a doubt, X-ray is not enough, please go for a CT scan or a CT-DCG. CT-DCG we started almost 20 years back. You can do a drop technique or a syringing technique. See, you beautifully know, see here it is blocked. Though the DCT has been done, there is a sac there and it's not going through. So there's a block. Here the sac has emptied and it has gone down, the dye has gone down. So it's such a nice way of delineating. Again, in the duct, you don't see the dye in the duct. Here you can see the dye. So both axial and coronal and even reformatting sessions are there now, which are very useful. The radiologist can play very many things on their system and they can help you. Adjacent paranasal sinuses, adjacent fractures, any bony details or anatomical variations can be picked up. Sometime in 2010, failed DCRs and traumatic NLD obstructions were the main indications why I got CT-DCG done. And they had 13 patients out of 25 associated sinus disease, which was not picked up or treated. So, and 15 patients underwent surgery, and the intraoperative findings correlated with the CT-DCG findings. So it's very helpful. Masses, if you carefully put in a Bowman's probe and excise the mass, you will not damage the canaliculus or the sac, but many a time it can happen. So this has to be recognized. So, and even for other surgeons who are dealing with tumors in this area or reconstruction, it's very important to make sure that the nasolacrimal system is working well. What's the use of putting a good implant or a graft or a flap there if you have underlying infection or subsequent infection? So this is what happened. Here there is underlying infection and she had a beautiful flap for an inverted papilloma, but there was a discharging sinus, same as in this case. So this has to be recognized. And as one speaker pointed out, these can be medico-legal issues as well. And this patient went for a routine MRI for a headache and he was noted to have a lacrimal sac mass. So this, we did a CT-DCG, made sure that there was no communication with the sac, and even intraoperatively while we're excising that mass there, which was just an inclusion cyst, the sac did get damaged and a DCR was also done. Prior permission was taken. In trauma, recognition is very important of the lacrimal system injury. But of course, ABC is very important, airway, breathing, circulation, much before you analyze what's happening to the eye. A thorough investigation is needed. Anatomical considerations, see what's happening to the bone, soft tissue. Usually there's a traumatic telecanthus where the lacrimal sac gets displaced along with the medial part of the bone there. So it's not very easy to work with damage or trauma in the medial canthal region. And you should realize that the mid-face is the weakest portion. So mid-face trauma is very, very, very prone, and nasal trauma, you're more prone for lacrimal sac injury. So you have telltale signs, xenophthalmos, rounding of the medial canthus, so many things. And of course, you can always, once you identify the punctum canaliculus, do a thorough clinical evaluation. And when in doubt, please go for, anyway, the patient needs an imaging. They will need a CT scan with 3D reconstruction. Might as well do a CT DCG also in the same sitting. So this, you see, here it looks hardly anything sinister there. But when I explored the wound under GA, just see the clot gave way and I have a huge gape there. Luckily, I had taken consent for DCR and proceeded. Whereas on the right side, which looked a little more deep, but on the table, I just cleaned the clot. It was not, nothing was in the sac was not involved. So thorough evaluation is an important aspect. And of course, you must have your other colleagues, the cornea colleague and the retina colleagues, because any intraocular injury should tackle that as well. Or if in case that is more severe, finish that first and then take care of the sac. So primary repair, secondary repair, all this intubation and all that has been discussed. But in an important thing, when you work with maxillofacial surgeon team, please request them not to put the plate right up to the medial aspect, where they can damage, sometimes an iatrogenic damage of the sac can occur. So this should be avoided. And if you are dealing with a later problem, make sure the imaging is done. And if the plate is extending right up to the medial wall, this has to be removed before you do the DCR surgery. See, this is another case where this plate was going right up to there. And see, this is a traumatic telecanthus rounding. And even after intubation, she's not very happy. Patients are not, here there was a trauma with a bulgur injury, a callus had formed. So an external DCR had to be done along with an endoscopic DCR, because in the endoscopy, all this bone could not be debrided. Early canalicular repair, we all would agree, gives the best results. And these days, the monocanalicular stents, especially the ones which are coming from Arvind Eye Hospital, are excellent. They have got very good results. So if there is an associated fracture, please do the DCR surgery first, then tackle with the orbital fracture. If there is infection, no point in putting an implant or a bone graft or whatnot. Same. So just deal with the, Dr. Chitra already asked me, so if there's a soft tissue repair, deal with that first, then take care. But of course, whatever you do, the canaliculus can never get back the full integrity unless you've done a good primary repair. However well you do, some amount of defect will be there. So try to repair the canalicular region with an intubation or a monocanalicular stent in the first sitting itself. Even if the other canaliculus is intact, if it's a young patient, please go ahead with repair in the primary sitting. And of course, in elective cases, if there is very acute abscess, prefer not to drain. And if it's a recurring infection and you're planning an elective DCR, please take care of the infection first. You may need to give them even intravenous antibiotics. And this patient begged me because his marriage was coming up to do cosmetic surgery, but he had a discharging sinus. So we had to do a good DCR first, then the orbital fracture was subsequently taken care of. So post chemotherapy, I find a lot of patients don't do very well because of the reduced stretchability of the skin. Sometimes post chemotherapy, when you do a DCR, they can come back with recurrence later on because of reduced healing. Also diabetes, bleeding tendencies we have already discussed, and poor patient compliance. And canaliculitis, I can't overemphasize. You have to pick it up. Everything is not such straightforward like this. You have to pus, let out all the pus, do repeated flushing. I don't believe in this this one single snips technique, 2 snip, 3 snip. I think in 32 years, I have done only one in sometime in 1996 and gave it up after the first case. I don't believe it. Javed also mentioned that he also does it. Try to express all the contents. We don't get scephazolin, but you have other alternatives now. These are the main organisms, actinomyces and nocardia. And every time after flushing in the OPD, it takes about 2 to 3 months for the infection to clear. We reconstitute the drops and give. I leave behind some ointment inside the canaliculus. So that also helps. Punctal stenosis is invariably after a viral keratoconjunctivitis or a viral conjunctivitis. So elicit that history. This patient developed the stenosis after viral conjunctivitis. So you initially just try to dilate and open up. don't allow it to go completely into a contraction or a stricture. So the key is that, and if not, leave a monocanalicular stent. Of course, Stevens-Johnson's and other conditions, skin conditions are really a headache to treat because of the associated anterior segment issues. But of course, you try your best. Repeated dilatation of the punctum and syringing is what I do. I don't try to put in stents or tubes at all in the first sitting. Very rarely I put in stents, only if it is needed. Suspect fungal infection in patients who are diabetic or immunocompromised, and all the more now with this COVID issues. Be careful while using powered instruments in lacrimal surgery, especially endoscopic DCR. And if you are working with an ENT surgeon who's very fond of powered, and see what happened, these powered instruments pulled on the medial rectus and optic nerve. The patient was NPL on the table. You don't want this disasters. Leave alone loss of the eye due to the infection. We have rare cases where the pus goes behind, and due to NLD obstructions and lacrimal sac abscess, loss of vision. I've seen about 3 cases, but use of powered instruments, I think nobody will forgive us. They will only sue us. Good nasal decongestion before surgery and a good nasal packing, you can't overemphasize. In fact, I used to do some DCTs long back in the past, but once I learned endoscopic DCR sometime in 96, I have not looked back. I have hardly done DCT except in very rare cases, as Mohan mentioned, for tumors. It's only DCR, and my anatomy knowledge improved after doing endoscopic DCR and external DCRs. I'm a strong believer of 2 flap techniques, like especially when Shruti showed her beautiful video. I really hope she didn't excise the posterior flaps, because she had wonderful both lacrimal sac and nasal mucosal flap. If you can give instant mucosal lining there, nothing like it, Why go and excise the posterior flap and leave bare bone and allow it to granulation tissue will become more. And you can't say stop breathing. You are going on breathing. You are going on having all the insults there. So it is naturally profound recurrence. So if you can give instant mucosal lining, nothing like it. Avoid DCT. This is a patient who came to me with repeated infections after 2 DCTs. And I opened up, I salvaged some amount of sac tissue and did a DCR. I gave a big ostium. Textbooks say 1 centimeter. It's not enough. You need at least 15 millimeters to 18 millimeters of ostium, because the beautiful work which was done earlier endoscopically, when you see them after 3-4 months, you have the ostium starts shrinking. So at the end of the day, if you have about 3 to 5 millimeter, you're really very lucky. Even if you have a 1 millimeter ostium which works, it's fine. Now again, even after that, I realized the patient has 100% patency after DCR now, after 2 DCTs, but still he's getting an abscess. I analyze the pus, he's going E. coli. It's so embarrassing to tell the patient you're having contamination, from your feces or urine or whatnot. It's very embarrassing. And this is a strange, usually it's Staph aureus, but he's growing E. coli, and maybe he has some amount of cellulitis. So if you can do a good DCR, please do a DCR and avoid DCT even in CAM patients at any cost. Thank you very much.
Thank you very much. That was a amazingly wonderful talk. I mean, we kept the best for the last. Thank you so much.
The youngsters.
It was really nice talk. Yeah.
Covering all much on them.
Yes.
Yeah.
So I think we are a little late. Arvind, would you want to take some questions before we conclude a very absolutely wonderful webinar?
I'm always amazed by Dr. Lakshmi's enthusiasm to teach and her eagerness to share her years of experience. And then she's been through all these. She's been in an institution. She's been in a private institute. She's converted from external to endoscopic DCR.
Not really. Not really. I do where it's needed external. I do where it's needed endoscopy, and I get mainly, I shouldn't say, sorry, Kachida cases. So, and I am not good as Javed to do the septoplasty. So I do take the help of an ENT surgeon for septoplasty alone.
I also do. Ma'am, it was very nice talk. We are very, very, very grateful to Dr. Chitra ma'am and Dr. Arvind sir.
I can't thank Dr. Chitra and Dr. Arvind enough.
I would also like to put on record Dr. Chitra's meticulous planning in choosing one surgery for an entire webinar and the choice of topics. I mean, they're as diverse and still as comprehensive for this particular surgery. and she has sat through the entire thing. It's probably like us, a DCR surgeon, sitting through a refractive surgery symposium and asking very relevant questions. So thank you very much for the opportunity, madam.
Yeah. All ARC you attend in, you see that she knows everything.
Right, Arvind. The only
Very
difference is
professional.
that Madam Chitra Madam has been asking relevant questions.
Yeah.
And if we sit through a refractive symposium, we'll ask tougher questions to them.
Yes, yes.
Very true.
I think Dr. Chitra sits through all these meetings.
She's really through it all.
I think she's become an institution by herself. The only thing I see is, despite all the publicity, all the hard work, the number of participants is what we have been talking to each other, isn't it? That's the unfortunate part. But I think that's fine. I mean, one motivated listener is better than a hall of 1,000.
Why are you saying that? I'm going to tell you how many watch. This is a little focused. Oculoplasty might have less attendance, but even then, attendance is good in these webinars. I think if I reached to 300 in this, I would be very happy. Of course,
and many watch it later. I have seen that.
It has gone, many of the webinars have gone to 1,000, 4,000, 5,000.
With time, people are not free.
Have contributed to a library for ARC, and that's so amazing. And I think, as I give my concluding remarks, I need to thank every single expert panel here for being with us, giving such volumes of information, the quality of speakers who are there in this particular meeting, and the kind of information which came through. It's not that it's my level of tolerance which made me sit. There was no way I was going to get up and go when so much was being poured over to me. And I think anybody who is not going through any of the other ARC webinars, it is their loss, because each of you have spent 2.5 hours and so much more time in preparing these talks. So kudos to one and all of you. At this juncture, I need to thank Dr. Arvind, who came up with such relevant, precise questions, and he's beautifully steered the webinar that I could even go and take some of those one-odd phone calls which happened in between. Kudos to you, Dr. Arvind. I need to definitely thank my ARC team who are always there with me, always supporting me in all my ventures. I need to thank Kripal and the AIOS admin for the SMSs which come and the kind of encouragement they give. Thanks to Sai and Manjula from Neurotech for all those mailers which come to you. I actually never actually thank, and this is the first time, I need to thank that young boy, Vel Murugan, who makes me realize all that I have wanted to do for ARC in these last 2.5 years. And I have to thank Encode for being that solid support for me and sponsoring all these ARC webinars of ours. And don't you think all of us in unison have to thank Mr. Sunil, who also keeps hearing all these webinars, who's our webinar admin. Thanks a lot, Mr. Sunil. And finally, I think we need to thank attendees for watching, and I'm sure they have gained. And I'm sure I'm the take a break, which I'm going to keep bringing in every week, would now onwards, or rather it has already started, would have a webinar clip also coming along with it. So people who have missed the earlier webinars, and if it is relevant to the subject, they could click and watch it too in case they don't access the website. Thank you very much, one and all of you. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you. Thank you, ma'am.